as everybody knows, the meeting is being recorded and will be put on the Trust website. We've got some people dialing in. Regular contributor Liz Walk, I think, is with us. And I think we've also got Liz Mackey from Health Watch. So welcome everybody. And I just want to draw your attention to the most recent Hero of the Month award, details of which are in the pack, and the actions of Dr. Duneva that got her that award. Congratulations there. So to item 2, are there any declarations of interest that anybody wants to make? I'll take silence as agreement. And let's move to the minutes of the Trust Board on the 14th of December. First of all, can I check with everybody that you're happy that they are an accurate record? If anybody has any amendments to make, Jackie?
I'm sorry, but there's a few typos. Do you want me just to send them to?
Yes, please.
I'll just send them to Peter afterwards.
Are there any that materially change the meaning?
I don't think so. It's just a bit of editing on sentences, I think.
Okay, thanks. Thanks, Jackie. Is there anything else from everybody in with those amendments? I will approve the minutes as an accurate record. Well, there's one matter arising. Vicky was going to confirm whether staff are required to relinquish electronic devices before going into the mortuary. Vicky?
Thanks, Chair. So there's not been any national guidance to suggest that staff should do that. And we discussed that there are other checks in place, such as CCTV, a clear description of rules against solo access and sign in on entry. I'm happy to look at other trusts, but I'm not aware that other trusts have put that in place. And many of our staff carry mobile devices for all sorts of reasons. So, but the simple answer was no, and there's not been national guidance to suggest that. Okay. If your investigations throw up anything different, will you come back and, of course, let us know? Yep. Okay. Any other matters arising anybody wants to pick up that are not otherwise covered on the agenda? Okay. In which case, can we go to the board committee feedback? Can we start with strategy, Jackie?
Thank you. I'll take the paper as read. I think it was very interesting to look at the community proposals and the totality of the services that although we're planning is sort of looking at them completely anew to come up with more integration and more seamless pathways. And so that was very good, that the work and the scale that the community teams are facing. Clinical strategy, that was the final version. A few comments were made, but it was acknowledgement of the huge amount of work that had taken place to get that far. In regard to digital strategy, the point was well made that it's more about a way of working rather than a strategy just in isolation. And on the estates, the understanding how we get from A to B would be important because it is quite a tortuous and potentially long journey, and the amount of investment required to keep the building safe is not inconsiderable. So those were the main points. I'm happy to take any questions.
Thanks, Jackie. Questions for Jackie? No, Nikki.
I just wondered, Jackie, do you have a timeline for the development of the community business plan and integration with acute services? And is that going to come back to your committee?
Yeah, it's going to come back, Nikki, because there's sort of reimagining what we've got now, it is a very big picture. So there are priorities, and they're around frailty and skill mix and developing further integration on some of the pathways. But there's an awful lot to do. So I think it is just rethinking it on a place base. The agenda is enormous, so no timeline as yet.
Did you want to add something to that, Richard?
Thank you, Steve, but only very briefly, and just picking up on what Jackie's last point was about in terms of place and the recognition that as the ICB takes its form and as we see what the ICB wants to do at place, obviously what we'll be looking to do with the community team and the integration priorities, as Jackie talks through, is ensuring that they fit with what we're doing at place and what the priorities are at place. And I think there is a piece of work that's coming to Stratcom this month that will begin to outline, now we know what the ICB's plans are increasingly looking like, what that will then mean and how that will play through to our teams as well.
Thanks, Richard. Should we move on to audit, Paresh?
Thanks, Steve. I'll take the paper as read. One thing I would like to highlight on this paper is basically due to operational pressures, we had to suspend a few internal audits. And despite that, we've been assured by our internal auditors they will give us a meaningful audit opinion by the end of the year. The other thing is basically we will have a mini off-cycle audit committee later on this month because we could not cover some agenda items because some of the key individuals were unable to attend. So that's scheduled for later on this month. But I'll take any questions on the paper.
Thanks, Paresh. Questions? No. Okay, thanks, Paresh. Should we move on to the Quality and Safety Committee, Amanda?
Yes, Chair. Following the same theme, I'll take the paper as read, just pulling out a couple of issues. The committee actually commended the executive leadership on how very, very balanced the risks were being managed, given the huge and significant pressure of COVID on the organisation and the impact on staff and absences from work for a variety of things. So there was a real recognition of how difficult it had been, but actually how the focus on quality and safety had kept the organisation in a good position and patients safe. Although there had been some areas of concern, namely pressure ulcers were an issue that we're looking at more closely. We did have a reduced attendance because of operational pressures, but generally the committee was assured that everything was being done to keep patients safe, quality of care as high as possible, and a keen eye on the key areas. Ockenden, we saw the usual report and again sought assurance that we were making progress against Ockenden, and generally maternity was under significant pressure due to absences and other issues. And as you note in the report, we had some inquiries from CQC, which was being dealt with by the executive.
Thanks very much, Amanda. Any questions for Amanda? Thank you. Finance and investment, Nikki.
Thank you, Chair. Again, I'll take the report as read. So I think the key headlines will, excuse me, talk about the BAF in due course anyway. In terms of operational performance for this year, a positive message really, expecting to hit the year end with a balanced position, which I think we should commend not only the finance team but the operational teams as well for having a real focus on that, and that being balanced alongside those priorities that Amanda's just talked about, keeping people safe and delivering as much activity as we can within a financial envelope is a difficult challenge. So I'm pleased to be able to say that we appear to be able to do that this year. That takes us on to next year, where unfortunately the challenge looks really significant at this point in time. So we talked around how big that challenge is likely to be and some of the key elements that we will need to think hard about in order to achieve a balanced position next year. and the work is ongoing to understand how we can do that next year. And obviously it's a moving feast, as we've seen in the last couple of days with announcements from the centre. So I think that's a sort of moving feast at the moment. In terms of business cases, capital and project approvals, the committee approved the recommendation of spending £600,000 to refresh digital hardware, which is part of the ongoing cycle of updates. And we also approved to spend on the improvements to Western Ward, which mainly have a focus on infection, IPC. I think that is the key headlines. If there's any questions from anyone.
Thanks, Nikki.
Oh, sorry, the only other thing I think we have spoken about and we should flag is the delivery of the capital programme, where I think we're conscious that we have some concerns about the need for run rate to increase significantly in the last couple of months of the year. But the committee were assured by the estates team that they are doing everything they possibly can to spend the full budget.
Thanks very much, Nikki. Damien?
So just to support the 2 points that Nikki flagged as risk, I'd like to talk more about it when it comes to the balance scorecard element of the finance. But there's risk about making sure we deliver a backloaded capital plan, and the scale of challenge to next year, I think significant is a polite way of putting it.
Okay. Okay, thank you for that. Thanks, Nikki. And people and OD, Caris, in your first role in the chair, first meeting in the chair.
Thanks, Steve. You won't be surprised to hear that we focused a lot of our time on the workforce dashboard this month. So really reflecting on the commitment and the contribution of our people and their well-being support, the retention work we're putting in place to make sure they really feel supported. We also talked about the great progress in terms of the trainee survey results that we've made as a trust, and I thank everybody who's contributed to that. And we also spent a great deal of time, which I believe is right, in terms of our Speak Up Guardian, Steve. I know we've had great results in terms of the culture feedback we've had, and we're really proud of that. But we don't want to become complacent, and therefore I'll make sure that it's something that keeps coming back to board to make sure as a leadership team we're continuously focusing on this.
Thanks, Caris. Questions? If there are none, I just wanted to say a word of thanks to Miranda for having been in the chair of the pod committee for some time, and for the progress that's been made across all of the main domains in that field. So Miranda, thank you for everything that you've done over all of that time with the People and OD Committee. I know that colleagues in the Trust, exec colleagues, and particularly colleagues in the HR department have been very appreciative of your role and where it's been needed, the support that you've given to the process. So thank you.
Well, thank you very much, Steve. It's been a privilege to serve in that capacity, and I'm very pleased that people issues are getting the emphasis they deserve now from the NHS.
Yeah, thank you very much. Okay, let's move on to the Chief Exec's report. Jo.
Thank you. Morning, everybody. So colleagues will cover off much of what I'm about to talk about in more detail, so I'll do it at a fairly high level. So I suppose the first thing, since the last Trust Board meeting, we've managed to get through December and January, so that's good news in its own right. It has been one of the busiest times, and that's really been, a lot of our time has been spent on planning for the expected Omicron surge. We were expecting potentially to have a double or even more, but a doubling of last year's high numbers, and so we had spent really much of December planning for something that might come. We are lucky or grateful, however we want to put it, that we didn't see those sorts of numbers. And I know colleagues will pick that up in their sections earlier, but to give you some idea, we're a little ahead of where we were in wave 1, and luckily nowhere near where we were in wave 2. But we had to be ready for it, and so it has taken an awful lot of time in terms of planning for something that might come and making sure we've submitted plans and providing assurance up to our ICS and into our regional and national colleagues in NHS England. Our staff absences will come up. I have to say it has been particularly challenging because whilst we have luckily seen not so many sick people, we have still had high numbers of staff affected, and I know Steve will pick that up a little bit in his update. That said, through the very hard work of teams and some innovation along the way, we have been able to maintain most of our services and ensure that safer staffing levels have been achieved. As I say, colleagues will pick that up in a bit more detail. So I do want to take the opportunity to thank all the staff who've been working hard to continue to deliver safe services for our patients. It really has, people have gone above and beyond again, and I would like that minuted and noted because they have worked absolutely fantastically. Worked hard to maintain much of the planned care activities, as many as we can. And although the COVID numbers remain the highest since we saw since last winter, we're now focusing really in our minds around a reset and refocus on recovery, which is quite hard because the numbers have not come down yet, but we do need to be focusing on beyond today and tomorrow. We need to be focusing on next month and next year now. So again, a lot of the times for the senior teams is being refocused on that. I'd like to thank colleagues who have led and set up and delivered our patient-facing vaccination hubs at Eastbourne and Conquest. And we've had the roving vaccination services. Steve may pick some up. I do want, and I haven't put it in the written document, but I particularly want to thank you, Steve and his team. We have stood those services up at incredibly fast pace. I know everybody's been involved one or another, but I would like to acknowledge Steve's input. I can see his face, so I'll move on from that. But thank you, Steve. It's taken your leadership to do that at such pace, so thank you. We did redeploy some staff. There was a lot of training involved, but we did pick that up and meet all of the NHSE requirements for that in really sort of days and a short number of weeks. So that was brilliant. I've been to see the voluntary team in the last week. I've been to A&E and a number of other places, but I also wanted to just take this opportunity to thank the volunteers. They are working incredibly hard as well, and they do make a difference. So I just wanted to acknowledge that publicly as well. If I just move on to a few more things. So from a strategy perspective, and I know strategy is taking up a reasonable amount of the agenda today, so I won't go into too much detail. But just to note, we are obviously in the middle of consultation for cardiology and ophthalmology. A number of us have been involved in some public meetings, talking through, particularly with our lead clinicians, what the service proposals are. And we're working in partnership with our CCG colleagues as well, because it's a joint consultation. Consultation is due to finish on the 11th of March. And again, take the opportunity for staff and public alike to be able to feed back in through the formal routes that are on our website. Again, very important that we get all of that feedback as much as possible. You'll recall that we are due to take ownership of the private Spire Hospital, which will be owned from by the Trust from 1st of April. We'll update in due course. We're still finalising some of the detail of that from an operational and a workforce perspective. We will have a brand for that unit, which will be Sussex Premier Health, but actually it goes beyond the unit at Hastings, and we'll look at all of our private patient services, as well as some NHS work that goes through those facilities as well. The important thing to remind people is that this offers us the opportunity to help recruit and retain our clinical staff, particularly our consultant staff, but it's not just consultants that do work there. it does offer patients a choice, and of course any profit that is made, and that's not normally what we use in the NHS, but any profit will be from that business unit put back into clinical services. So it's really a win-win for us, and we're quite excited about that. And just a final bit on estates. I'm sure the capital conversation will come up again a bit later, but just in terms of a few things. So again, the leadership team have been focused on responding to the winter and pandemic sort of over the last few years. So I've just noticed a typo, apologies. But the Conquest Cardiology Cath Lab is being refurbished, and construction is due to finish in early February with the new equipment installed. And so it's operational in mid-April. The latest stages of the extension to the Conquest Emergency Department is underway, and the modular build is due to be completed in early April. And that's really to support our clinical teams. The extension to what patients will see has already been completed. Eastbourne in the A&E has seen quite a lot of developments over the last few years, but there's another one in progress at the moment. And this is due to end in May, and again to use best use of the space that we've got at the moment. There's a couple of areas that need some refurbishment and integration with the rest of the department. We've got a new recovery area being built at Eastbourne, which will allow the day surgery. So we've got a set of day surgery theatres at Eastbourne, but this will allow for us to use that as a day surgery unit. Some years ago, it was repurposed and integrated within A&E. Happy to show non-execs around because that makes far more sense when you can actually see it. But that will allow us to have some dedicated green space to improve our elective throughput and particularly our day cases as well. And West Ham is being refurbished so that we can create dedicated red and green areas, which allows better operational use of those two spaces if we don't have, as we reduce our COVID numbers, so that we haven't got sort of empty beds on a ward that we could be using for green patients. You'll be aware already, but we are working through the next 3-year capital plan that will come through to committees and then board over the next few weeks. So I'm happy to take questions, just recognising that questions you might have, we might leave until the IPR section in due course. Thank you.
Thanks, Jo. Any questions colleagues want to pick up with Jo? Karen.
Thanks, Jo. Do we have any indication about the level of feedback and engagement on the cardiology and ophthalmology transformations? Does that all lie with CCG at the moment? And then following on from that, kind of what's the timeline? Because obviously we're 2/3 of the way through the consultation. What's the timeline after the consultation process?
So I'll probably bring Richard in for some of that. We've done a number of engagement sessions and we are due to have some interim information coming back from the, I think there's a draft through, I just haven't seen it yet. So we are due to have sort of an interim position. The information comes into an independent body, which is ORS, and they collate that for us. So it doesn't come in directly to us and to the CCG. So that they're able to provide an independent report, and there will be a final report. But just in terms of timelines, Richard, you're on mute. So
I am on mute, sorry, someone had to do it. So in terms of timelines, obviously, as Jo said, the ORS will collate the report and that'll be by March. There will also then be a workshop specifically to deal with cardiology, not so much ophthalmology, because there is a site preference. As we know, what's slightly different in cardiology is that we're not going out with the site preference. So the workshop will be undertaken immediately after the end of the consultation period. That will be a stakeholder workshop, and then that will essentially come up with the recommendations that will go to HOSC in, off the top of my head, I think it's April, but I will double check. Just to come back for a second on what we are hearing. So what we are hearing is there has been a tremendously good take up of advice being given, thoughts, comments into the ORS consultation site. At the moment, what we are hearing is that broadly, there is general agreement for the models of care that we are proposing for both ophthalmology and cardiology. And generally, what tends to happen is there is people from Eastbourne are saying we'd prefer the Eastbourne site for cardiology. People from Hastings are saying we quite like it to be in Hastings. So it's actually going in exactly the way that we thought it would. Broadly positive around both models, which is great from our perspective, and obviously depending upon which site is closest to the individuals feeding back, that's the preference they're giving.
Great, thanks, Richard.
No problem.
Any other questions for Joe? Okay, in which case let's move on to agenda item 7 and the integrated performance report, and as always start with quality issues, and start with you, Vicky.
Thanks, Chair. So I'll talk to the November data that's in the pack, but also, if it's helpful, give some headlines from December. I have to say both of those feel like quite a long time ago now. So Joe's already alluded to some of this, but in November, in terms of COVID, we did see local prevalence continue to climb, and just at the end of November, Omicron appeared as a new variant of concern. We did have some outbreaks, unfortunately, at that time, but they were very well managed, I think, with really close collaboration between clinical and operational teams. Shifting into December then, in terms of COVID, we really saw Omicron took off, and it became very apparent that it's far more infectious than any of the previous variants and has a much shorter incubation period, so highly infectious and spread within 2 to 3 days. Thankfully, thanks to the vaccination rollout, the impact of that clinically is far less in terms of severe illness and death for most people, albeit not all, sadly. The operational impact of that is small outbreaks, but we are continuing to see that. The infection control team continue to work closely with site colleagues and the ops team to try and manage that. And I'm sure Steve will talk more about the impact on our people, and Tara, I'm sure, will talk about the impact operationally. Sadly, we have seen that the very recent national easing of restrictions is now starting to present some real challenges for some of our staff, and we have some patients and visitors no longer wanting to wear masks or follow some of the infection control guidance. We have refreshed all of our comms, our posters, our policies and our social media sites to ensure that everyone is clear, and the ICS position is clear that for health and social care, the requirements will continue. There's been a number of changes with regard to reviewing the isolation period for positive and exposed patients in hospital, and we've taken that through our clinical advisory group and to the incident management team with recommendations made. In terms of C. diff, the position at the end of November was 47 cases against an internal limit of 38, with 9 cases in December and January. So the Trust is very close to the annual limit at the moment. There is some discussion nationally and regionally about more widespread use of antibiotics in the community as part of admission avoidance, really as a result of COVID. So that may be relevant. But on a really positive note, we've still had 0 MRSA bloodstream infections year to date. So that's very positive to see. Amanda's referred to the increase that we saw in November in terms of pressure damage, and there's a deep dive underway, and we'll report that back into the Quality Committee. An initial quick review suggests that there may be some revalidation of the data required, and in out-of-hospital data, there may be a small number attributed to care homes or nursing homes, so not to ESHT. So we're looking at that. I think there's also some further work to do in terms of damage that occurs in patients' own homes, and just making sure that where patients have capacity and decline or refuse treatment or advice, then we're really capturing that in our records. The Pressure Ulcer Review Group are doing a lot of work at the moment, and they have seen in the last 12 months that where we've had 4 clusters of pressure damage, all of those have been linked to COVID outbreaks. And we think that may be as a consequence of the strict infection control requirements. So patients are less likely to wander around and be mobile in an outbreak. And also, if patients do have respiratory symptoms, then they're probably more likely to be sat up for longer periods of time, which is increasing pressure in the sacral area. And we're certainly seeing that in the kinds of pressure damage. So lots of work still underway there. In terms of revalidation of the category 3 and 4 damage in November, unfortunately, we have seen an increase in that. So we have full root cause analysis underway for those, and we'll report those back into our weekly patient safety summit. I'm sure others will talk more about the significant amount of new and additional capacity that we've needed to keep open over the last few months, and that has continued to stretch our nursing workforce, unfortunately with some gaps at times, so that may be relevant. But I think overall, most of the quality metrics have really held up very well, considering all of the challenges. In terms of patient experience, I'm glad to say that we saw a positive reduction in the number of open complaints in November, and all of the teams have been working really very hard to try and improve the response times. And we did see an improvement in November, which we've managed to sustain actually in December and January, despite all of the busyness. Our friends and family test recommendations rates were again higher than the national average across the board. We had a small number of reopened complaints, and they covered core services, medicine, DAS division, and women and children, with no specific themes or concerns for me to escalate. We do have a new and more detailed patient experience report, and we've taken that to the quality committee. And we have a divisional focus at the performance reviews as well. In November, the Trust received over 2,200 plaudits, as well as 7 reviews posted on the NHS website, with all of those leaving either a 4 or 5-star review. Similar picture in December, and we had a small number of complaints about West Ham, which we reviewed. One of those was actually from a year ago, and 2 others about communication, so working with the clinical teams on that. Finally, really just to touch on workforce, although I know Steve will provide more detail, November and December continued, as Joe said, to be really very challenging, not just in terms of the additional capacity required, but also the impact of Omicron on our workforce, with staff either needing to isolate or indeed testing positive themselves. And we did manage to do our data collection as planned in November for the next nurse establishment review. I would say, just as an overall summary, that really despite the continued pressures over the last couple of months and the impact on staffing, that largely the quality indicators have really held up very well. And I think that's a testament to our incredible staff, and I just want to add my thanks as well for everything that they've done and have been doing. I'm happy to take questions, Chair, before I hand over to David.
Great. Thanks very much, Vicky. Very helpful. Questions from colleagues? Jackie.
Thanks, Vicky. There's just 2 questions for me. Given the number of breaches on the 12-hour, what measures are we taking to keep people safe when they're in the department for longer than we would want? And second question, our discharge before midday is only 16% against the target of just over 30. What's the reasons why we're unable to get people into the discharge lounge before midday?
Sure. So in regards to the first question, and maybe Joe or Tara want to provide more detail for the second, if patients are unfortunately in the emergency department for longer than planned, then both departments have regular huddles and they have intentional rounding, so are checking on patients that are there in terms of vital signs, hydration, comfort, pressure area care, and all the things that you would expect. So I'm assured that they are doing all that they can. Clearly, it is not the best environment, especially for frail patients or those with cognitive impairment, to be there for very long periods of time. But I think that they do have checks and balances in place to make sure that they're providing the best care for patients while they're in the department. I don't know
Did
if
you
Joe wanted to add to that, or Tara, in terms of your question about discharge planning before midday.
I'm just going to let Tara come in first, if that's okay, and I'll see whether she picks up what I was going to say.
Tara?
Oh, I feel like it's a test. So with regards to the discharge, on the Eastbourne site, Polegate is obviously our area for discharge, and that is currently a bedded ward at the moment as part of the winter escalation. On the Conquest site, we still have the live discharge lounge, and we do put the patients into the discharge lounge. However, we have to remember a lot of our patients, we work with our partners with regards to transport. So it's making sure that we can get as many patients out in the morning, but we have seen not just us experiencing issues with staffing, that our transport partners are seeing issues there as well. So they are prioritising the patients according to journey, numbers of crew that's needed, etc., etc. So that has been an issue, Jackie, and we haven't forgotten it, but obviously it's something that we're going to address as we start to get checks and balances back into play with staff. We don't actually not report that. We do monitor that on a daily basis, and obviously for us as an operational team, we're very, very keen to make sure we get the patients' beds ready for new patients as quickly as possible. As an organisation, and I'll touch on it in a minute, our performance with regards to patients that are being discharged as P0s, that are patients that do not need to be going to onward care or new onward care, we exceed the national ask. So we are doing really well with that. It's just that we're not doing it in the right time of the day.
Okay, thank you.
Joe, did you want to add to that?
It was just pick up on the 12-hour bit, really, just so there's no confusion. So the 12 hours that we're talking about is 12 hours from arrival. They're not 12-hour breaches. There are new standards coming in, which Tara will pick up. We'll do a session on that separately. But just wanted to be absolutely clear, they're not 12-hour breaches. That said, the reason the new standards are coming in is that we don't want anybody in the department more than 12 hours. But I just want to differentiate between the two. They're different standards.
Yeah, good point, Joe. Okay, if there are no other questions for Vicky, thank you, Vicky. David and mortality.
Thank you, Chair. So although you've got the November data in the pack, I've seen the December data and signed it off, so I'll talk to both if that is okay. So the shimmy is 97 for both November and December, so that's from August to July and from September to August, if you see what I mean, moving on 1 month. So it's stable at 97. The RAMI has fallen from 86 to 84 across those 2 months worth of data, which puts us 23rd out of 124 trusts, so we're still firmly in the top 20%. Crude mortality has also fallen, and that's excluding deaths from COVID. The issue regarding the depth of coding differences between Conquest and Eastbourne is still being investigated. It's proving a very knotty problem to try and get to the bottom of. Every time I think we've cracked it, it turns out that isn't the cause. So further work is ongoing with that. In terms of causes of death, we're back to a more typical picture in terms of pneumonia being the main cause of death, followed by sepsis, followed by cancer, and COVID is down to 4th in the current data. In terms of absolute deaths from COVID, October there were 8, November 24, and then December 12. Mortality from COVID is still largely related to the Delta variant, which we know is more severe, but there are a few deaths creeping through now from Omicron, particularly in the unvaccinated. So although it is clearly more benign, it's not totally benign. And if you are unlucky, elderly, frail, unvaccinated, multiple comorbidities, it is still potentially a fatal disease. And so I think people need to be aware of that. I wanted just to say a very quick word about something that isn't in the pack, and that is that around Christmas time, we were asked at very short notice to set up something called a COVID Medicines Delivery Unit, or CMDU. This was a national requirement because of some new data which showed that certain drugs prevent or reduce the risk of death or requirement for hospitalization if you pick up COVID. So if you get these treatments in within the first 5 days, they are very beneficial. And so across the ICS, we have set up a process where patients who are clinically extremely vulnerable, if they develop COVID, within 5 days, they are triaged by some pharmacists and then go to a medical triage, and then we decide what medication to give them. And the main medication we've been giving is a neutralizing monoclonal antibody called sotrovimab. And to deliver that, we've had to set up this COVID medicines delivery unit, which at the moment is in the A&E at the Conquest, and patients come up and have a Venflon put in, and they're given an infusion of sotrovimab. And actually, it's been really successful, and the people that we've been treating have not ended up in hospital and have felt much better very quickly. There's also some oral medication that we're able to give for those people who don't want to attend hospital. And there is a new development of an even more effective oral medication called Paxlovid, which is coming in this week, starting on Thursday, which will actually take the pressure off the intravenous infusion unit. And so we'll have to rethink how we deliver that. But major thanks really to the people who've been involved in setting this up for me. It was done at very short notice and has been very successful. A lot of hard work by some individuals. But so I thought I would just mention that. That's it from me. Thank you, Chair.
Great. Thanks, David. Very interesting and encouraging points at the end there. And I just wanted to say we sort of got used to the shimmy and the rammy being really good numbers, but every now and again you take a step back and you think, do you know, that is a real success story that we shouldn't be overlooking, particularly when you think about the pressures that we've been under over the course of the past 12 months. It's really quite remarkable, I think.
Yeah, certainly if we go back 5.5 years, the shimmy was 112.
Yeah.
So, you know, it is in a much better place. But still more work to be done just to get to the bottom of some of these subtle differences. But yes, you're absolutely right, in a far better place than it once was.
Yeah, and it's too easy to be sanguine about it. Nikki.
So not to detract from the point that you've just made, Steve, this is far more mundane. Your slide, so I've got it as 17 of 51, I think. The main cause of it in hospital death groups, and we can see COVID and pneumonia, etc. When I first saw that, I was pondering the sepsis up there, because I recall we've had a conversation previously about all the work that's been done there and reducing that number, and I couldn't recall off the top of my head whether 16 was high or not. So it was just a request to maybe contextualize that for us a bit more, whether that could be a graph so we can see how it's changing over time, because I think in your commentary the suggestion was actually that that's not changed and that's completely normal, but I couldn't see that from that picture.
I mean, sepsis is always in that graph as one of the top causes of death. So if you look at the December one, which you can't see, it goes pneumonia top, sepsis second, cancer third, COVID fourth. The other ones that creep in there intermittently: heart failure, MI, stroke, COPD, are the standard sort of main causes of in-hospital mortality. Our mortality from sepsis has plummeted since we did the massive sort of sign up to sepsis campaign. But you're right, it hasn't gone away as a cause of death. I mean, I could probably, instead of having the depth of coding, I'll put a sepsis graph in for you next month, Nikki, so that you can see how it was.
Thank you. I guess what I'm getting at is just enabling us to see the trends, so that if there was a line going the wrong way, we'd be able to see it.
Okay.
Thank you.
Thanks, Nikki. Thanks, David. Any other questions for David? Damien.
David, it's probably my lack of understanding, but is there a way of being able to tell whether overall mortality, including COVID, is different to prior years?
Well, there's different. The trouble is, there's many different ways of looking at mortality, Damien. So we can look at crude mortality, and so, for example, we're around 1.3% compared with 1.6% for last year, and we've got previous figures. At times, you know, we've been as high as over 2%. The shimmy and the rammy, as you know, then take that crude mortality and apply different methods of comparison, looking at the risk factors for death in people admitted to hospital in different ways to give you a better comparator between trusts. So, you know, there are so many different ways of looking at it, and there isn't just the shimmy and the rammy. There are other, there's SHMR and other different indices that you can use. So it is quite a complex field. I give you on a monthly basis shimmy and rammy because I think they're probably the two most important, but I actually get a mortality on a monthly basis, get a whole mortality pack which analyzes it sort of every which way, if you like. So I've got weekday mortality, weekend mortality, I've got mortality between the two sites split the same way. I you know, it's a sort of a 8-page document with multiple cuts as to how it looks, and I sort of select what I put in this report. But there, you know, I'm happy to share the wider pack with you, Damon, if you'd be interested.
Sure.
Great, thank you. Amanda.
Just following Nikki's mundane kind of queries, really. I just wondered if there were any conversations going on throughout the ICS about quality reporting across the ICS as part of our integrated performance report. Because it would be good to see some comparators and the system as a whole.
I don't see any mortality data in that regard, Amanda, but there is quite a lot of work going on from NHSIE and their sort of quality wing, which is sort of partly GERFed and partly no longer GERFed, looking at outcomes across different surgical specialties across ICSs. And so we are starting to see that data coming through with comparators. And then, of course, there are various national analyses of different areas with, you know, national joint registries and other national reports. There are lots of them in cardiology, as you know, which compare us with other trusts. But we are more and more seeing dashboards for different specialties looking at performance across a trust. And it's not just quality, it's other metrics, although they're related to quality, such as length of stay and readmission rates and so on. So there is more of that going on, and we as the quality of that data improves, I think it's the sort of thing that we should be sharing at board.
I think just before I come to Vicky, I think the certainly the thinking of the emergent leadership in the ICS is that there will be more of a collaborative approach to kind of subcommittee reporting, where we'll take a kind of collective view about the things that we should be looking at together that give an added value if we do that. But I think that'll take a little bit of time to get itself up and running. Vicky?
Thanks, Joe. I was just going to say, Amanda, so the chief nurses across the system have been having conversations for quite a while before the pandemic and during, and we're keen to look at exactly that so that there can be some helpful comparisons and benchmarks. And we agreed last week that for the whole system and not just health, that we all think a focus on mental health, and in particular children and young people's mental health, complex eating disorders, self-harm, really now is something that as a system we want to work on together, and that will be true regionally and nationally. So I think we're working towards that.
Thank you, Vicky. That was kind of my thrust, really, because I think there are some benefits from tackling some of the ICS priorities, the acute collaborative, and bringing it back to board. Thank you.
Thanks, Vicky. And I think that list that you just gave us would be, I mean, that would be a really exciting range of issues to be working on with local authority and other partners, because it's of interest. It's an area where we know we don't do as well as we might, and good things for us to be working on as a whole. Excellent. Okay, thanks everybody. Should we move on to workforce, Steve?
Certainly, Chair, and good morning, everyone. I guess as in recent months, the people report feels somewhat out of date by the time it comes to board. So what I'm going to try and do today is provide an overview of the key data, but more importantly, give you updated information based on our current experiences. I'll also provide a short update on our vaccine as a condition of employment, the mandatory vaccine programme, towards the end, because I know you'll all have seen some significant changes on this over the last week or so. So I think it'd be helpful for the board to be updated. As we've already discussed in other sections, our trust performance during December was challenged due to the continued number of escalation beds that are open across the trust, the ongoing high attendance, the arrival of Omicron, and we've seen further challenges, with that one, especially due to the transmissibility of the variant, the number of outbreaks. And I think, as Vicky pointed out earlier, this has not just resulted us in having more beds open, more beds closed, and our flows restricted. It's also placed sort of significant pressures, I think, on our staff, because we've had less staff, and the staff we've had have been spread, more unusually, I guess, across the organisation, and that creates a challenging, stressful, and I think a stretched environment for them. I think the ability of our staff to keep going, of our colleagues to keep going during this time, is a true testament to their commitment to deliver great care at ESHT. And we really have seen people, stepping up and doing things that we wouldn't normally expect to see them doing in order to support us. Now, one particular example of that I wanted to bring to the board's attention is around a new role that we've put in place, which is a ward support worker role, where we've trained a number of our staff who are typically non-patient facing to undertake this role. We've identified over 100 people who have come forward to support our registered and our unregistered nursing colleagues should we need to either open further additional capacity, or if our available staff numbers drop further. These staff have been through a training programme which actually provides them with the information they need and the support they need and the skills they need to be able to work alongside our registered and our unregistered staff, not in delivering direct care, but doing all of the activities around that, which will make life easier. And again, I want to thank the number of people that have come forward for this. I think the role presents us with a unique opportunity going forward, not just to create the cohort of individuals that we might need now, but actually to have a cohort of people for the future that we can keep motivated, we can keep trained around the role. So in any future crises, be they to do with sickness or to do with major incidents or whatever, we've got this group of people we can draw on. So I think something really good has come out of that. I've talked quite a lot so far around being stretched, and that probably brings me quite neatly onto sickness levels. And what I'll do in terms of sickness is I'll talk about the picture as it stands today, because clearly, as it was in month 8 or month 9, it feels a long time ago. Our sickness levels have risen significantly in the last month as a result of Omicron, with more staff being off. Additionally, we've had some typical winter illnesses continuing to play their part and placing additional pressure on us. As at last Friday, we had 163 staff off with COVID out of a total of 455 staff off. That's 5.7% of our workforce. This doesn't include the additional 66 staff who are isolating, which takes it to 6.5% of our workforce. This puts us fractionally ahead of days lost in the previous year and well up on the circa 60 COVID and 340 total sickness we had about a month ago. It is worth saying, however, though, when we talk to colleagues in other organisations and other trusts, we are doing well in terms of our attendance, and we're doing well in terms of our sickness levels, though clearly we would want them to be lower. If I move on to some of the other headlines from month 9, our substantive staffing has remained broadly similar to the last month. We've seen a slight increase in the vacancy rate, but this is due to a small number of new roles. Turnover continues to increase very slowly and has moved to 10.6%. If we remove planned leavers, this number reduces to 10.1%, but that's still above our target of 9.9%. So we need to keep a watch on this. And we've placed a real focus on retention in our health and wellbeing efforts now. I think it's very clear that we're recognised from a health and wellbeing perspective at being very, very good at what we do. And with probably the law of diminishing returns, we feel our efforts now really need to focus on retention. The number of temporary work shifts requested in the month was the highest we've seen in the year, and the number of filled shifts remains relatively static on the previous month. Effectively, I think in terms of our temporary workforce, we're at the point where the requests for shifts outstrip the available workforce, and we'd expect to see fill rates below where we would want them to be in the short term, at least. That's not unexpected given the levels of sickness that we're seeing across the trust. And what we are doing, and what the site teams are doing a fantastic job of doing, is making sure that we are putting the right staff in the right time so we can deliver safe services throughout. So in summary, I think it's been an incredibly tough period in terms of meeting the staffing needs of the trust. We believe that throughout we've maintained safe staffing levels, but at the same time we've prepared ourselves to deal with additional surge through both facility escalation plans, staffing escalation plans, and the development of new support roles. Our hope is over the coming weeks we'll see the prevalence of Omicron reducing, and this will both return more of our colleagues to work, as well as reducing the need for escalation areas that cause such a challenge. A couple of other things just to talk about briefly. Firstly, Joe mentioned the public vaccination hubs. We were asked in mid-late December if we could set up a hub on each site to support the national booster effort. We set up 2 hubs in less than a week each and contributed to the booster targets being met across Sussex. We closed the hubs in January, having run them over the Christmas period, so that we could focus on the delivery of our primary services. I would like to thank everyone that played a part in what was an enormous effort to deliver the hubs so quickly. I think it's only when you get involved in things like this that you realise just how much work takes place. Finally, I want to move on to briefly talk about the mandatory staff vaccinations, or VCOD, to give it its official name. This has been a massive project and has a real impact on many colleagues, both across the trust and in HR. As you'll be aware, announcements were recently made regarding the intention to revoke the legislation, which required all colleagues engaged in the delivery of healthcare, or those working in areas where it's being delivered, to be vaccinated against COVID. The legislation is currently being consulted on before coming back to Parliament, and in the meantime, we've been asked to suspend any action against employees who did not comply with its requirements. We've now done this and are taking no formal action. However, we are still encouraging all staff to get vaccinated to protect themselves, their families, and our patients, as we believe this is the right thing to do. We'll also continue to seek the vaccination status of new applicants to roles in the trust, and until the requirements, the legislative changes and the subsequent NHSE guidance that we expect are clarified, we're holding off on offering posts to applicants who fall in scope and are not willing to be vaccinated. This is a very small number of people, so it doesn't actually have that much impact on our recruitment at all. As with our existing existing employees, our stance is that vaccination is the right thing to do. In terms of the stats, at this point in time, we have 93.4% confirmed compliance with the legislation. 504 employees that are in scope roles have not had the vaccination, or we don't have data on them. And we've identified 77 staff who are in scope and have declined to have the vaccine. As I say, our approach remains to encourage our staff, but it's unlikely, we believe, that legally they will have to have it going forward. This has clearly been a very difficult project, and one which is coloured by many different views and opinions. There's no doubt that it's had a negative impact on relationships between colleagues across the trust and between some individuals and the trust itself, regardless of the fact that we've been asked to enact legislation. I do want to thank all of our colleagues who have come forward and been vaccinated, but equally importantly, I want to thank all of the line managers who have supported the process, and my colleagues in HR who have been leading on delivering what has been an incredibly difficult piece of work, both in terms of the effort required, but I think also emotionally a difficult piece of work. Clearly, we'll keep the board updated once there's further clarity on the legislative changes and guidance. One final point from me, and I know it's been mentioned already, I would like to thank Miranda for your support with POD in the time I've been here, Miranda. It's been very much appreciated, and I feel with your leadership, we've really been able to move the committee forward. So thank you. I'll stop there and open to any questions.
Thank you, Steve. I have to say, on the mandatory vaccination, I joined a couple of the the open staff workshops, and I thought the HR team and the occupational health team that ran the sessions did it superbly. Really did an excellent job of handling what is a difficult conversation with some quite passionate views on either side, and they handled that very well. So much credit to them. Karen.
Thanks, Steve. Two questions from me. Given the high level of sickness and the extra hours that many staff are having to work, are we building up a risk around holiday accruals? I'm just thinking we're getting towards the end of this year, and if we are, how are we going to deal with that? And then a second question around the mandatory vaccinations. Do we have any indication that there are any complaints from staff, unvaccinated or those who are not wishing to declare their status, in terms of their conversations with managers? And you may not have that information to hand, but I just think it's something to look into at least.
So in terms of holidays, Karen, and I'm sure Tara will back me up on this. One of the things we've done this year, based on our learning probably from previous years, is actually we have encouraged throughout the year people to take their annual leave. And we've actually kept a very close eye on that. Yeah, one of the things when things are tough is actually people not taking their leave is unhelpful rather than helpful. So it's something we've really focused on, and I don't believe that we're going to have a massive sort of influx that we're going to have to deal with at the end of the year. And in fact, we've been very clear about about people not storing up leave and carrying it over, because we don't want to hit that point. In terms of mandatory vaccinations, I said before, it's a very emotive subject. There are probably quite a large number of staff, some who have been vaccinated, who don't like the don't like the legislation, didn't support the legislation, and are unhappy. And I think all of my exec colleagues will agree that we've had many outspoken or many comments made, some of them very emotional, regarding this topic, and it's something that we've sort of taken on the chin, as it were, and said people have a right to feel passionate about this. But in terms of it causing any sort of significant or particular issues, we're not aware of any as yet, though. I mean, clearly there's noise in the national press, and there's noise and there's some noise about people who feel that they've had the vaccination when they didn't want the vaccination, but that certainly isn't something that's that's come to us as yet.
Thanks, Steve. Jackie?
Thank you. One of my questions was related to what Karen just raised. I'm just wondering if there has been any breakdown in team cohesiveness amongst teams, if some people don't want to be vaccinated and some people do. Have we got a way of putting teams back together again? And my second question was on the rota compliance, getting the approval rates. I note that there's new planning tools have been put in place. I was just wondering how that's going, because not having your rota approved is a real irritant for a lot of staff.
Yeah, thank you, Jackie. In terms of supporting teams, Steve mentioned about the drop-in sessions that he attended earlier. We have been running drop-in sessions, which are everything from sessions for people that are vaccine hesitant, don't want the vaccine. And we talk about how we can support people. We talk about the information, but we also a key message throughout everything we talk about is about being compassionate, and it's about being kind, and that's really been, I think, the mantra of the whole of this this project to us. I don't think we are aware of teams where things have really broken down. There are passions, and where there are passions, we're working through the HR business partners, through my colleagues, to support line managers in dealing with that. But I don't think, yeah, I think this is, I think everyone recognises that ultimately this is about individuals' opinions and individuals' views. And I think we've got a workforce which is mature enough to recognise that people do have different views and they might not agree on them. And this is a particular topic where probably people will never agree. So really, I think quite a mature approach to it is what we're seeing, although people do want to give their views. In terms of compliance, I mean, clearly one of the real challenges that we have at a time when it's so difficult is getting through appraisals.
Sorry, I meant rota compliance with rota planning.
Yeah, so I mean, in terms of the rota planning, our 8-week rota has improved quite significantly. And our 6-week rota has gone from being around sort of 30 to 40% to now running at just 50% compliance. I mentioned to the board, I think a couple of sessions ago, that we're really focusing in on rota compliance, and it remains an area of focus for us. There are a lot of rota changes at the moment because of not necessarily when people are working, but where people are working because of sickness, and we're very conscious that that has a negative impact. So it's an area where we haven't achieved what we do want to achieve yet, Jackie. We're on an upward trajectory, but I think we've got more to do.
Sorry, the November report says that the approval rates have dropped. So are you saying that November is better?
In December they've come back. So I've got the month 9
okay,
date.
All right. Okay, thank you. That's fine.
They're back up again, and in fact, the 8-week score is the highest it's been since January 20.
Okay, thank you.
Thanks, Jackie. Miranda?
It was first of all just to thank you for your tribute, Steve, but secondly, I wondered what staff morale is like now, given that the Omicron wave has not been as bad as we expected, and leaving aside the issues about vaccine hesitancy that you were talking about, how are people feeling?
So I guess I can give some slightly hot off the press information here, in that in the last 48 hours, I think it was the last 48 hours, we've actually had a first cut of the staff survey results from last year. What they tell us is, along with many other, in fact, the vast majority of trusts, actually there are a range of scores that have gone down. But there are 8 people promises, one of them related to morale, and we are in the top 20% of trusts in terms of morale, and we've held our own in terms of morale. And I'm really, you know, I'm absolutely delighted about that. So, yeah, at a time when things have been really tough and many organisations have slipped backwards, we've sort of stayed where we are. And morale is of the people promises, the one where we've actually performed the best. Now, that is not to say that people aren't tired at the moment, people aren't frustrated, people aren't very, very challenged at the moment. And I absolutely do not rest on my laurels, and I know none of my colleagues rest on their laurels around this one. It is tough out there, and we need to continue to recognise it. But I think hopefully what the staff survey result there suggests is that, you know, the focus that we're having and the focus on health and well-being is actually helping us to look after our people.
Thanks, Miranda. Thanks.
Very good, thank you.
Vicky?
Thanks, Chair. So, Miranda, I'd just to support Steve, we've been looking at our COVID roadmap and we've kept it under close review all the way along. And because of pandemic and with Omicron, a lot of the team building things that we would normally do, we've not been able to do that face to face. So staff spending time together, you know, socially, but also even you know, training events at work, it's been quite difficult. So we're really keen now that, although Omicron certainly hasn't gone away and we're still very challenged, we're looking at how we can risk assess that and do that safely, because we really want people to get back to spending time together at work, so it's a key thing for us, and I'm hoping that will just help relationships, because it's been really difficult, I think, you know, forcing people effectively to stay apart at the most difficult time probably that they've known, you know, has been really tricky. So we're hoping that we'll be able to get back on track with some of that soon.
Thanks, Vicky. Any other questions for Steve? Otherwise, let's move to Tara and access and responsiveness. Over to you, Tara.
Thank you and good morning. Firstly, I'd just like to welcome Abigail Jago, who's online today and joining us as a public member. She actually joins us as the Deputy COO for Elective Care on the 7th of March. So she's here today for her first induction session. So I will take the month 8 report as read and pick out some of the key highlight areas from month 9. As others have said, it's moving on at pace. But I'd first like to start by thanking all of our amazing teams from all modalities across the sites. And we've seen so many stars that have sparkled brightly and continue to shine through Winter Sparkle and onwards through the perfect week or National Operation Reset that we've seen through January. And that's especially in light of some of the pressures that you've heard from Vicky, David and Steve so far. Our EDs have remained busy and our teams have performed well against these challenging times, and December saw ESHT place 34th in the country out of the 113 trusts. So again, that shows that although it has been tough, we continue to perform well. And as we've gone through January and into early parts of February, we have seen where we have flow that we are improving. We've even seen best in region, not that to make it sound like it's Crufts, but best in region for the ED performance. And I think that's really important to acknowledge that as well. In the last public board, I talked about a system called Livy that we were in the early stages of introducing, and I'd like to just give you a brief overview of some of the results that we've seen in the first 7 weeks. That takes us up to the 23rd of December. We now have a full 12-hour, 7-day-a-week rota with GPs in place. And the data is showing that we've seen 623 referrals from 111 diverted to Livy, and also where there is capacity still available in the system as it's coming up and running, we've managed to redirect 126 appropriate patients from the front door. So those patients have not had to sit in our ED departments. They've been able to go home. They are obviously appropriately streamed and safe to do so, and they're having their appointment with a GP via Livy. So in real terms, this equates to a reduction of 606 patients not having to stay in our ED departments across both sites. And we have an 84% completion rate. So that means 84% of those patients that have been seen via Livy have not had to return for further treatment with us. So I think that's a real success, and we continue to monitor that. In line with that, we look forward to the 11th of March. We have eConsult coming online. So that means that as patients come through the door, they can check themselves in. They will answer a series of questions, and we will be able to use them, the results of that, to redirect appropriately. And again, we are also working on another pilot where we can redirect appropriate patients to community pharmacies with an electronic referral. So there's so much going on at the front. I don't want to dwell on performance and not think that we're not looking forward, and we are, and we're looking at doing that in line with the new ED standards that I won't go into today, but we will go through in the coming weeks and months. I think over the Christmas and New Year period, we've seen an increase in the number of patients that are actually unavailable to come in for elective procedures, either due to the understandable reluctance to wanting to self-isolate prior to an elective procedure, especially as it's the first Christmas that they felt that they could get together, but also our elective performance has been impacted by the staffing shortages. However, it is good news. Still in December, as a trust, we ranked 25th out of 111 trusts with RTT. So again, although it's not really being monitored, we continue to strive for that. Across the region, we are one of the only trusts with 0 patients over 78 weeks. And we continue to perform well with FDS being delivered again in December. That's the faster diagnostic standard. And although our cancer performance hasn't reached the national target, we have delivered in line with our trajectories that we said. So again, the recognition from the system and NHS England, in fact, that we know our business and we do deliver. And that was quoted to me directly by one member of the ICS, that we are recognised as a trust that delivers. So I think that's really important that we hold on to that and we make sure our staff recognise that as well. Again, another update, Palantir, or Foundry as it's known, we continue to progress at pace with the implementation of that system to help us understand and manage our waiting lists, and that gives real communication and two-way communication and timely communication with our clinical teams, and they have access to their waiting list when it is live. We are working in partnership with Chelsea and Westminster Hospital and learning from their experience of implementation, and we are currently working to look to see if we can have some shared resource with them as well. So bringing in some of their data quality team that have already gone through this process and that we're working and bringing them in, and Damien and I are in communication with other organisations to make sure we do this in other areas where possible. So the validation is going well. We have been successful in securing some resource to validate our waiting lists, and we continue to work that forward into all of the different pockets of waits. And we're going to ensure that we look at our recovery programme and look at our admin processes in light of Palantir to see where we can improve our processes, our validation exercises, and make sure that our data is as clean as it can be. Linking back to the comments made earlier, in the community setting, we continue to work with our local authority and other system partners to expedite discharges and onward care for our patients. But now we're also focusing more on admission avoidance from the community and how we can work with virtual wards. I'd like to really recognise the hard work and the support that we continue to receive from our community teams. They have gone over and above in many cases, supporting the vaccination hubs and also the Perfect Week and Winter Sparkle. During Winter Sparkle, we saw a reduction in our length of stay, but what has really stood us in good stead, as I mentioned earlier, is our ability to discharge patients on a P0 pathway, those that are going back to their original point of residence. We have a national ask of 50%, that 50% of our discharges are on P0. There are many days where we are actually exceeding 90% of our discharges are on that P0. So they are the patients that we are making sure get the right care and are discharged quickly. And that's also within our own ability to discharge. So as we move back to normal, we're looking at the community programme being reinvigorated, and we are working as part of a system to coordinate all of the plans that we need to put into place there. So as an East Sussex system, we are working to determine a strategic approach to our out of hospitals requirement for the next 18 months. We have proposed an audit be undertaken of what is currently happening to determine need, complexity and acuity along with the trends. We will test whether there's seasonal variability and how the new ED standards will impact on what is required. This demonstrates that as a whole system, we're now focusing on the complete patient pathway and also continuing to build on lessons learned through COVID times. It has been a difficult month, difficult few months, but what I can say, and to provide some assurance, I really think that as staff morale is concerned, our teams work really well together. We have built a lot of new and different relationships over the last few months. And we are using all of our technology in a different way now to enable us to ensure that we are safe. Our site meetings, we use the Safer Staffing Wheel. That comes up and we understand where staff have been placed, where shortfalls are, and we have real live conversations about how we work together. So as I opened, I will close with a real thank you to all our teams that support the delivery of all of this, and for their ongoing support as we go forward, because we aren't underestimating the ask as we go into the recovery phase. And over to questions.
Excellent. Thank you very much, Tara. Jackie.
Thank you, Tara. It's really helpful. I guess I'm left with the feeling of how much of the change from pre-COVID to now is the new normal. It seems that people are coming to ED because they are, and we can't get people into social care because of closures or staffing. So how much of this do you think is now normal? This is how the system works now, because that might tell us something about what we need to do in the future.
I think, to be perfectly honest, that's why we've asked for the audit as part of the reset of the community programme, to really understand what the new normal is. We have had an Ipsos Mori audit undertaken, or survey undertaken, that does demonstrate that some patients are struggling to get GP appointments, so are coming to the ED by default. But I think this is where, with the systems that we've got in place and the communication, we are pushing back through 111 and educating patients. So I think the new normal is still to be decided, but there is an element of we are open 24/7, we are there, so patients want to feel safe, they come to our EDs, and we are working to make sure that we can signpost them to the right place, or at least where we can let them leave with an appointment. So UTCs, SDECs, 111, Livy, they are all going to be really key. And we do also work with our walk-in centres and promote them. So we do have some capacity to redirect patients to the right place at the front, but it really is dependent on us making sure we've got the streaming nurse there to do so. And with regards to how we unfold as we go forward with regards to COVID and what that looks like for the elective programme, and how we can support community with regards to getting patients back to their original care home during that IPC phase. Vicky and I had that conversation this morning. I think that's still unfolding. We're still waiting for national guidance on that. So I don't know what the new normal is. I wish I did.
Yeah, I'm thinking, if people choose to come to us for a primary diagnosis and primary care initiated, it's how we then communicate with GPs when we hand that care back, because they've not been involved in that initial visit. So I think there's something about how continuing care passes back to GPs and getting them involved. But it's just interesting, because this just feels like how it is now.
So GPs are, we have, the Urgent Care Board, we have LAEDBs, Health Watch, and the GP forums, primary care, are all involved in that. So we have many system meetings with GP representatives. So it's not that this is happening in isolation. No, they are fully aware. So we feed back what's happening, and obviously if we go through, say, Livy, and there's a GP through that, then via care records, the GPs are aware of what's going on.
Okay, all right, thank you, Tara.
Nikki.
Thank you, Steve. Tara, this may be because the papers we were looking at were perhaps a little dated, and a lot of what you've spoken about, I think, possibly addresses this. But when I was looking at this, it felt like a lot of the solutions that, or sort of remedies that we were putting in place, were focused on investment in ED because we're not meeting the targets there. But a lot of the problems that we were talking about in the paper were more to do with flow and getting people through the hospital, and that blockage that we seem to have at the moment, where we're really struggling to get people out. And I just have a slight concern that we are investing in the bit we control because we can. So we are optimizing at all costs that ED department. So we're putting in UTCs, we're putting in various pieces of IT. But I'm nervous that we are putting a lot of money into something that ultimately can't fix the problem, which is that people are turning up in the wrong place. And once they're here, we can't get them to where they need to be as well. So in terms of taxpayer bang for buck, are we putting money and investment in the wrong place? And the bit that ESHT controls is going to be amazing and the best it could be. But that's not the actual solution to fixing things like people sitting in A&E for too long. So I guess it's a really complex thing, and I think you spoke a lot about it with your sort of your talking piece, if you like, today. But I just have this overriding niggle that maybe the money's going and the investment's going in the wrong place as a system.
So I'll come back on some of it. I'm sure Joe will want to come in as well. But with regards to, are we invested in the wrong place? No. I don't believe we are, and it's not about performance at the front. This is about making sure that when patients do arrive with us, because they will, whatever they always have done, that we can redirect them to the right place in the right time, so they don't have to sit and wait in an ED for us to turn them around. Also, if patients aren't coming through that section, we're not going to admit then it's not an onward problem, and that's why I was trying to reiterate that we are seeing this as a whole pathway now. And if you look at the new ED standards, and I don't want to get drawn into those because that's another lengthy conversation, it's about how we can turn patients around at the front so they don't come through. But if we do, then there's a clinically ready to proceed. So it actually moves patients through a pathway quite quickly. When we're looking at the back end, I think there is, our teams are amazing, and absolutely, if I look at, when I talk about our teams, I've got my community and acute hats on, and they work so well. They are one team, they're intrinsically linked, and we do push patients into the right beds where we need to. And I use the word push because actually we are pushing and pulling as well. I don't think we're investing in the wrong place. I think what we are doing is making sure that we have ED departments that are fit and ready for the future, and we're future proof for the new standards. We've also made sure that we are working really closely with our local authority colleagues, and we are doing some things really differently for the future with regards to patients going into virtual wards, how we support those, and then also how can we bring that into the acute setting as well. We're looking at social admission type lounges, so that's run by our AHPs, so that we can just put patients in there, a little bit of workup, and then go because they don't need the clinical needs. So there's a lot going on. It's probably better, Nick, if we just do a walkthrough one day and just start at the beginning and be a patient and pretend. Sometimes I think that's the best way to do it. Is the way I understand the referral pathways. I came in as a bit of paper and followed it through. I literally walked through the pathway. So happy to do that with you, and then it's probably easier to explain it as we go through.
Thank you, Tara. I'll definitely take you up on that.
Yeah, it's a better way of doing it than the way I've been trying it, I can tell you that. Joe, did you want to add to that?
Yeah, just slightly. So Tara's articulated that very clearly. I'm with Tara, and don't put his hand down. I think it's a really good challenge and the right question though, Nikki, because if we started from scratch and as a system we had the right resource in the right place, which meant patients didn't need to come to our front doors, then yes, we've right-sized for the demand. And I think the question is, could we reduce that amount of investment if we could invest in a community? And I don't mean our community services, I just mean in the community pre-hospital. I think the reality is that theory's been worked on for a very long time, and the numbers continue to increase. So, but they are exactly the discussions we have as a system about where you invest your money at the front door. I always think A&E, and apologies to A&E colleagues, I think their staffing is relatively simple because it is just a case of capacity and demand. It's not that, because you've got to have the right people and skills and things like that. So I think the investment that's been in there is historical investment that is in line with the increase in demand. That said, just to bring back to the system conversation, and Damien, I know, was having conversation through the finance leaders group, there is a conversation about the things that aren't in our control and whether we as the NHS invest in transition, if you like, between acute care and social care, if you like. And they are the conversations about how we as an NHS can plug that gap. Do we plug that gap? Because, and so they're quite complex discussions, but Nikki, they are the absolutely right question to ask. And I think possibly it's worth a seminar discussion at some point, or certainly an F&I discussion with some of that challenge, and particularly through our transformation work that we're doing as well. So sorry, that was slightly long-winded, but I think we need to keep that challenge up, actually.
Thanks, Joe. Richard, were you looking to add something on that point?
I was, thanks, Steve. I think Joe's talked a bit about it already, but I do think the question's terrific in the sense that what it actually allows us also to talk about is those things that we do not fully control. Tara's talked about the importance of virtual wards. I think when the system is looking at its new governance model going forward, what we're trying to look at is to say, are we enabling all of these things that are already going on across different organisations to come together and to discuss how we make that effective. So, for example, if we want to influence currently the moving forward through virtual wards, the way our system collaboratives are set up is that individuals have to attend 3 different meetings because the collaboratives are very settings focused. We've got the mental health collaborative, we've got the acute collaborative, we've got primary and community collaborative. If what is, I think, terrific about the new governance structure plans that seem to be emerging is about saying, if we're going to make integration work, we need a governance structure that brings organisations together rather than splits them into settings-based tracking and monitoring. So I think it's back to that bit about in those, so ED is within our control, but actually when we get to the back end and when we get to things like virtual wards, new models of care, we're going to have a system approach to governance and a place-based approach to governance that will bring the right people into the room more effectively than we have been. And I think that will really help Tara and the team take things forward. I was just going to add that bit, really.
Thanks, Richard. Thanks, Nikki. Miranda.
Thanks very much, Tara, for your usual masterful summation of a lot of your areas. What I wanted to ask about was cancer, where some of the metrics are stubbornly difficult to shift. And we've had a number of august individuals and institutions during the pandemic warning us of a potential time bomb of cancer mortality and morbidity that might come through because COVID has taken up so much of our resource and our attention. I just wondered what you're doing to bring your magic and your grip to bear on the cancer pathways.
Thank you, Miranda. As you know, it's very close to my heart. But we, the first thing I'll say is that we have never stopped operating on our cancer patients. So we have maintained where we can all of the performance that we've been doing. So far, so what am I doing about grip? Just this week, just yesterday, I've started one-to-ones with the service managers to go through their patient waiting lists. So I'm going through each individual waiting list, looking at all of those patients that are long waiters from an RTT perspective, but also going through those cancer patients. Now, there have been some issues that we've had experience that have been outside of our control. One of the things that we have experienced, and all of us have experienced, is that the histology labs that we send to, they experienced staffing shortages because of COVID, so there were some delays there. Achieving the faster diagnostic standard is absolutely key because it means that we are pulling patients at the beginning of the pathway, and that gives us more time. So the grip and control that I've had before on cancer, where I've personally done that. I've kick-started that ahead of Abigail, who I welcomed in, so she's hearing it now before she's actually stepped across the threshold. I will hand over the baton to Abigail when she comes in March. So I believe we will start to see a turnkey in those patients. We've also got an element of patient choice, which we have to understand and respect. Some patients have not wanted to do the isolation for procedures during this period of COVID, and obviously some patients have had COVID as well. So it's a real mixed bag, but I can assure you that we are reviewing all of those patients that are long waiters. Our 104 days are under control. We are in line with our trajectory. In fact, we're ahead of our trajectory where we said we would be. So we are on the road to recovery for cancer. It remains a #1 priority for us. So yeah, I will maintain my grip and control on that one as long as necessary.
Thanks, Tara. Glad to hear it.
Thanks. Joe, your hand went up. Did you want to add to that?
Yeah, it was. I don't want to add particularly what Tara said, other than I just wanted to pick up sort of potentially the inference around inequalities and possibly the patients that haven't come forwards. So one of the biggest concerns, I think, that was almost within that question is the patients that haven't come forward. So it is worth just looking at the data on 2-week wait referrals. They are back up to pre-COVID levels, so that's a good sign for us. We have to manage it, but it's a good sign. I think one of the things with our new inequalities leads, so Richard's leading on inequalities, and the public health element of that, so it's working at place level, is to try and understand almost what's the right number of patients to be coming through. We absolutely are seeing people come through the unplanned route or even planned route too late in their pathway. And we need to encourage people to come forwards. So we do need to do that inequalities piece of work and the public health piece of work, but we need to do that as a system. So Richard, but also with Abigail when she comes in. Nothing like teeing Abby up for readiness on day one.
Thanks, Joe. Richard?
Just to come back in on Joe's point about the health inequalities, and I think Tara knows this as well. We got some data through around health inequalities and the impact thereof, because it's been analysed at a Sussex-wide level. We need to go through it in more detail, but at the moment, I think a very quick skim would suggest there isn't an enormous differentiation when you look at the various strata of deprivation across our patient base. But as I say, we will bring something back through the board to demonstrate that we're looking at that specifically. But at the moment, there isn't an enormous gap from the data that we've currently seen. And literally, this is hot off the press. I think it was yesterday evening we got it. But that does look a little bit more encouraging than we feared. But as I say, it needs more work. But I want to just to update board members of that.
Thanks, Richard. Nikki, is that a new hand or a legacy hand?
It's another question, I'm afraid, Steve, if that's all right.
That's excellent.
Sorry, Tara. Apologies if I've got the wrong end of the stick, but there was this gentle hint in your report that the escalation wards themselves might be driving the need for the escalation wards because you stretch the staff further, you increase length of stay. And I just wanted to explore that. Have I completely misread something? Because it wasn't something that had occurred to me until I thought about it. And then I thought, actually, that was a really interesting point.
So I think in a way, what it is, it's our ability to discharge. So if we aren't able to discharge because a patient needs a double up package of care and it is taking time for that to be procured, then yes, it does cause a backlog in the system. We knew the numbers were going to go up. We've got the red and the green pathways as well. So I wouldn't say having the escalation wards is causing the escalation wards, but what we now need to do is work out how, because of seasonal variation, we've got to start stepping down those escalation wards. One thing that we're working on, again, I've started work with the local authority and we're doing through our OPEX group, is that's the week that was TW3. And what we're doing there is understanding what is going on in the community. So how for the local authority, so how many patients are currently sitting in spot purchase for beds? So it's, and that's not always just an acute thing, that is also from a community perspective, to allow our clinicians to start making different decisions right at the front. So we're starting to change the way that we look at patients as they come through the doors so that we can manage their discharge planning differently, and hoping that we don't have to keep patients for longer than necessary, which will help step down the escalation ward. So the escalation wards being open isn't a problem in itself. It's about the ability to discharge.
Okay, happy with that, Nikki?
Yes, thank you. I think I had got the wrong end of the stick, but thank you, Tara.
Great. Amanda?
Oh, Tara, thank you. Just your grasp of this is quite remarkable. It's really refreshing to hear. You have a response for everything. You understand the data, etc. Just exemplary. It's great to hear. And I'm going to be a bit of a scratch record, and because I've heard these conversations, we've had these conversations before, and yet this is the real opportunity, isn't it? We've got data that we've not had before that tells us the story. We've worked in partnership, collaboration, those words that we continually use. We've had some good results of that, but we've still got this thorny issue of flow, discharge, and front door. So I wondered if you could kind of articulate, because there is so much to go for and so many strands of this. What are the 3 things that would make a difference for our patients on the urgent pathway that we as an organisation need to really, really drive forward as part of the ICB? Sorry, place. I didn't mean ICB, I meant place.
So I think probably the conversation around that would need to link into the new urgent care standards. That would be one, and we'll go through that at another time.
Yeah.
I think we are doing the thing around making sure that if patients arrive at our front door, there are options rather than them being absorbed into our system. And then absolutely what we have seen in the last, and I can even tell you the days when we have good flow, and patients being discharged in good numbers, our ED performance is in the green. I've shown the board before, our little bingo chart that we get every day that shows the different colours against performance. And we have seen ESHT in black, which we know it has been an issue during long periods, but we've also seen us in red, amber and green, and performing best in region, as I said. So I think it is about, for again linking the whole pathway, is about urgent care. We need to see the discharges. If we can get the discharges and the flow to virtual wards, this is why it's so linked. So we need the virtual wards so we can move patients through and put them in the right setting and monitor those patients in conjunction with our other system partners and get the patients through whatever the pathway may be. It may not be one where they're physically in the hospital, but they are still part of our care system, and we are looking after them in that arena and stopping them coming back in. So working with the GPs, looking at patients that have been in for 14 days or more, and when they're discharged, flag them to the GPs to say, can you keep an eye on these patients because there could be certain concerns. So again, it goes back to that whole system piece, and we are starting to do that. And again, linking back in the way that our staff are engaged, we are making sure that we are doing this with our staff. They can see the benefits of doing it and really bringing people that, and I refer to our staff as stars when I was opening my piece earlier on. We have got some rising stars that are really keen to be able to do that, and we've allowed during Winter Sparkle and the Perfect Week for people to make pledges about they want to do differently. So I think that's probably what we've not had the time to do before, is really listen to the people on the floor that are delivering the care, and how we can make a difference. Sorry, Amanda, that sort of answers the question, but it is about, it's so faceted. It feels like Lego, and it's different bricks that we're building all the time.
But it sounds like virtual wards, a more consistent approach to virtual wards and getting patients out and keeping patients out is something that is shifting and changes the dynamic from red to green.
Yeah, green's where we want to be, upper quartile all the time.
Don't doubt that, Tara. Thank you.
Thanks, everybody. Thank you, Tara. Shall we move on to finance and Damien?
So thank you, Steve. It's going to be interesting to see if I can maintain the same degree of positivity that's flowing through the rest of the presentation. Just going back to November, we were coming out of half one. We saw the reduction in funding directly in the beginning of half two. We knew at that stage we had an 18 million loss of funding. During November, we began to recover that degree of funding. In fact, we secured 17.8 million on a non-recurrent basis, which meant that while in November we started with a 1.6 million deficit, we have been quietly building up through December, January, February, an improvement of £400,000 each month to basically aim for a recovery to break even by the end of the year. However, I just want to emphasize that 17.18, which was basically TIF bids, was non-recurrent, and therefore the concern is what happens when the funding runs out, and that becomes part of the challenge for next year. What we also have is a requirement to look at where we started pre-COVID at the 1920 position, and our current staffing is 532 people more than we had 2 years ago, and some of those are part of building community into a stronger position, and frankly that element is recurrent, but a large part of the 532 is not actually built into the expectation for next year. So that basically is the scale of problem we face. Also, in terms of delivering CIPs or efficiency, we had a target of trying to get to 15 million. By February, we are almost at that stage. But again, our efficiencies are in the main non-recurrent. So it makes the same point again. It looks good through to the end of March, and then we need to think fundamentally and consider ourselves against what exactly is our benchmark position and how do we improve. I'd like to just touch on a couple of the points made in previous presentations. So we've talked about the right level of staff through Steve's section and through in Vicky's section. There were points about how we were getting back to the right level of staffing. But if you look at those same graphs in areas like care hours per patient day, we appear to be higher than the national norm. So in all of those areas, we might need to. I'm sorry, I've got an echo. Those are the areas we're going to have to start to look at in terms of where do we get back to 1920 levels of costs in next year, in 22-23. I also want to touch on capital. So what's happened on capital is we had quite a clear plan about how to deliver this year. I mean, okay, we had a problem about some funding moving across from the end of last year. So we started a bit slowly, and then we received a lot of capital through November and December, and it's even still dribbling through now. And while we're managing the process effectively, we're looking at spending, or we're looking at being able to draw down cash through February of between 7 and 8 million, which will improve the position we're at the moment. But we will still have close to 8 million going through March that will become dependent on either some last minute finalisation of work or agreement of vesting certificates to underpin at the position at March year end. So we're aware of it as an issue, but we just need to highlight there's a lot of work to do to be able to land the capital position by the end of March. In terms of the summary page on risk and mitigation, this was the position as at November. There's been just one change since November, where basically we're now confident about the funding assumptions, which is basically the securing of the TIF funding, because that has happened through December and January. So we put it in this pack at 80% confidence, which has now shifted to 100% confidence. In terms of what we referred to as income disputes, and said we had probably a 20% chance at the time of securing an additional 6 months worth of 1.6 million. We're now saying that can't really be managed because it wasn't built into the current year within the ICS rules. We are looking to try to agree an uplift for the income that refers to in terms of next year, but we're now saying, you know, it's no longer realistic to be forecasting that. So from December we've changed that to 0% on income disputes and 100% confidence in terms of funding assumptions. So in summary, we're in a very reasonable state to secure this year end, but there are underlying concerns about getting to the funding for next year, which is largely focused on a baseline of 1920. And just a final note on that, and we will talk about the national funding agreement for 22-23 separately, but just to be clear that within the rules, we're being told that COVID funding will be 43% of this year's COVID funding. So it will be, that's a 57% reduction of direct COVID funding into next year. And again, I apologize for sending a slightly more financing message than my colleagues, but I think it's just at this stage we need to be aware of the scale of challenge we're facing.
Thanks, Damien. So I think you're telling us that it's highly likely that we will deliver our year-end revenue target.
Yes, we are highly likely to deliver the year-end, including the revenue position, including the CIP target, and including staying on top of the half-2 plan. The only two issues I am flagging is there is a lot of work to complete the capital position for year-end, and the scale of challenge to get to 22-23, which I know you've heard from Nikki previously and now from me. That is where the focus will need to be.
Yeah, and I'll come back to both of those, but I don't think we should pass over what we are saying about the ability to deliver the year-end revenue number. So I think this will be the third year in a row that the trust, if your confidence is well placed, and I'm sure it is, it'll be the third year in a row that the trust has delivered on its financial obligations, which I think, given the history of the trust, is a very significant position to be in. I think when I first arrived in the trust, I remember saying to Jonathan that delivering 1 year is fine, but it's only when you deliver 3 years in a row can you say that you've achieved something. So we're not there yet, but if we do, I don't think it's something that we should be as I was saying to David about the mortality figures earlier, I don't think it's something that we should be sanguine about. And I think when the time comes, it's right that we reflect on what it's taken to deliver both this year and for 3 years in a row. So so we'll come back to some well dones about that in the fullness of time, but I think that's great news. Could we say a bit more? Whether this you, Damien, or Joe, just about what it's going to take for us to improve the position on capital over the course of the next, whatever it is, 40 or 50 days that we've got remaining. I think, next year we can have a separate conversation about in due course, but if we focus on this year, what is that going to take?
So Joe, are you happy for me to start? So what I've emphasised so far is that it will come down to what happens in March. So broadly, we know it's a backloaded plan. We know a lot of funding came through in November, December, and in terms of delivery in March, it's not necessarily getting the spend agreed, but it is basically receiving the asset and finishing pieces of work to the satisfaction of reaching a vesting certificate stage. And what I want to emphasize is we're not just talking about estates, because a lot of the new funding coming through covers a stream of work, including digital and equipment purchases, in particular in diagnostics, and some elements of strengthening information, including the information team. So we are going to review in detail that 7 to 8 million of spend and make sure it's deliverable. There is some risk within it, and what I'd like to do is, in fact, I've already agreed with Joe that we will work through tonight to our own assurance. What exactly are people doing to make sure that will be delivered through the March?
Okay, thank you. I mean, I guess if there is that sounds like an important piece of governance, process chasing, getting people to be honest about where we actually think we are over the course of the next few days. I would personally find it helpful when you've got that kind of action plan, let's call it that for want of a better word, over the next few days. I would find it quite helpful to hear under separate cover. I'm sure other Neds probably in the same place like to hear what that looks like, and what kind of actions are going to be necessary. Does that seem reasonable to you, Damien, Joe?
Yes.
Thank you. Paresh.
Thanks, Stephen. I think Damien, firstly, like to add to, and the entire team, for kind of forecasting a balanced kind of financial year. I think that's quite an achievement. And when it comes to the capital review, I think we do have a meeting on Thursday. I don't know if it's an appropriate time to actually have a first cut of that. Just the earlier sight we have of that plan, the better, I think, to manage expectations.
Okay. I mean, I would like to emphasize that this has been, I mean, I know it's happened for 2 years in a row, but this is a largely coming out of the capital elements of the TIF bids. And because we receive an allocation late, it's quite, and you know, I even received an update last night regarding 2 million of it. It is very last minute to be able to make sure that all of these processes stay in place. And to be honest, this isn't just about building work. It's issues like, will equipment arrive if we're reliant from overseas delivery? Because frankly, the whole supply chain is higher risk than it used to be. But yes, I will certainly get that for you for Thursday.
Thank you.
Thanks, Joe.
I'm just going to, David's already said it, we'll come back with notes from that, whether it's an action plan or whatever you want to call that. It's a review that we've got later this evening, and that after that discussion we can share that conversation with people.
Yeah, that would be really helpful. Thank you. Any other questions for Damien? Going. Gone. Thank you, Damien. That takes us to the end of agenda item 7. We are running a little late, but I'm guessing that colleagues would still want the opportunity for a comfort break. Can I suggest, so I make it exactly 11:30, can I suggest we just take 10 minutes rather than the usual 15 and back at 22? Would that be okay? Great, thanks everyone. Okay, welcome back everybody. Let's move to agenda item 8 and the board assurance framework, and Richard.
Thank you, Chair. Colleagues, this is the Q3 update on those risks that, were they to materialise, could significantly affect the delivery of the Trust's in-year objectives. And I think, as we have noted in the board before, this now provides a good detailed approach, and I'd like to thank my colleagues for their review of the risks that are assigned to their own parts of the business. They have all reviewed Q3, and I think it is in reasonable shape. I also would draw members' attention to what we are trying to do for 22-23, which is basically to say, look, we are now in a position where we've got a new set of strategies that we'll come on to the presentation of in a second, and I think it's an appetite time to just have a look at, are these still the right risks? Are we okay with the controls that we've got in place? Because we know that 22-23 things are going to change, and so as we move from Q3 into Q4, we are prepared for Q1 moving forward for 22-23 with a BAF that reflects the strategic risks that we face as an organisation. So a little bit of housekeeping, and I think the section that we've got in there shows that rather than sitting on our laurels and saying, well, actually we're reasonably okay, what we're trying to do is look at a model known as the assurance radar. And that's something that Baker Tilly developed with NHS Confed. And I think, again, it's another way of saying, in the past, we've looked at the BAF, is it fit for purpose? We've reviewed it. And I think for next year, what we want to say is the coverage of the risks that we've got sensible? Let's look at what we can do. So I'm happy to stop there and take colleagues' questions.
Thanks, Richard. Let's open it up. Nikki?
Can't have a session on the BAF without me asking a question. So I think there's a bit of a lag, isn't there, in the papers that come to this meeting. So at the last F&I, we talked about the risks assigned to our committee, so 6 to 8, and most of the conversation was around BAF 6, because at the moment that risk wraps into it both delivery of current year finances and future, and at the moment, if that is a blended risk, what that does is hide both the positive that we think this year is looking quite good actually, but also the negative that next year and onwards looks really challenging. So the challenge we had in F&I for the execs was to think about whether it's worth splitting those two risks. It may be that next year, actually, it all looks really challenging and it's all one risk. But I just wanted to flag it to be minuted and at this committee that is something where the BAF at the moment perhaps doesn't reflect the reality of the situation that we find ourselves in.
Yeah, that's a good point, Nikki. And I think it goes to the point we were just making, which is I think that review of are the risks that we've got on the BAF the right ones, focusing on the right things, segmented in the right way, is actually something we're asking of all risk owners, to be honest.
Okay, thanks, Richard. Anything else for Richard from colleagues? Gone. Thank you, Richard. Do you want to keep the floor and move on to agenda item 9?
Thank you again, Chair. So we're now looking at agenda item 9, which is the supporting strategies coming to the board. And I think colleagues will recognise many of these because what we have done is they are coming here, having been approved essentially by the committees. They're coming here for recommendation. Well, sorry, they're recommended by those committees for approval here at the board. Colleagues will be aware of the work that we have done. And again, for the purposes of a public board, we're just reminding ourselves that we have 4 overarching strategic aims for the next 5 to 6 years. And what we have done as an organisation is to say, well, if those are the 4 high-level aims, how can we be clear that those enabling elements that we run and work on as an organisation support the delivery of those 4 strategic aims? And that's what we have in front of us here, the enabling strategies, if you like. And I think what's great about the work that colleagues have done is in pretty much all of them, what we have been quite explicit about is saying, how does this particular strategy, be it people, be it clinical, be it digital, how does that actually drive us towards delivering those 4 strategic aims? So I do think that we've moved forward in terms of having an internally coherent set of strategies. The work obviously begins now. And again, I'm doing an advertising piece for the next Stratcom. There is a paper that's going to Stratcom this month, at the end of this month, around how we begin to tie all of these together and start evidencing that these strategies are not just sitting on a shelf. They are informing the work that we do as an organisation. They are consistent with place and system thinking. So that is now happening. But what we're doing here for the benefit of the board is to say these are the strategies and we are presenting them for recommendation. Happy to recommendation for approval. Sorry, I'm happy to stop there and take colleagues' questions.
Thanks, Richard. As you say, they've been through the various committees and they've been looked at by us as a group. Miranda.
Thanks, Chair. It was just with regard to the clinical strategy in particular. I wondered how it is aligned with the ICS approach or will be aligned with the ICS approach when they know what it is.
So I think it's a very good question. I mean, one of the bits of work that we're doing with the ICS at the moment is looking at how we impact outcomes. And the ICS, if you think about the ICS's strategy, Vision 2025, it's largely outcome focused. I think what we've sought to do in our clinical strategy is ensure that when we've gone through those core statements talk to the 4 or 5 outcome areas that we've got within Vision 2025. So I think we are aligned, but you're absolutely right. It's about ensuring that what we're now doing as what the strategy asks us to deliver is actually we can evidence that and it's consistent with the system. I think broadly it goes back, the same point can be made about our wider strategy. What we've done from the very beginning is try to make sure, given that we know Vision 2025 is going to shape Sussex and place, let's make sure that everything we do is consistent with the outcome areas within Vision 2025.
Joe, did you want to add something to that particular point?
Yeah, I suppose it's a comment to get across all of them, but just to bring back to Miranda's point, it's very difficult to write a strategy at the moment because the NHS and the health and care systems are changing, I would say at some pace. They're evolving and emerging conversations. I think you have to draw a line in the sand and recognise that as those things emerge, we would then need to update our strategy, which is why we always said that our overarching strategy was an interim one. As I work with colleagues and our team work with colleagues as an ICS, but it is a system. We've already said we've got a place-based, we've got our system-based, and then you've got direct provider to provider conversations as well. I think those will evolve, and as I say, at the moment they are aligned, but we need to recognise that updates may be required on a regular, whatever that means, whether that's annual basis, as things emerge over time. I think we also have to recognise that NHSC strategies are changing and emerging, and priorities changing on a fairly regular basis at the moment. So, but I'd say that against all of those strategies. But yes, it's aligned for now.
Thanks, Jo. Nikki.
Thank you, Chair. I just wanted to say that the one I found sort of really interesting to read and most reassuring actually was the digital strategy, because I think 6 months, a year ago, there was some nervousness around how we would pull that together. So I found that a really good document. And one of my favourite bits of it were the colleague and patient stories that were intertwined in there. For me, that raised two questions. The first one was, are we being sufficiently ambitious? Because in a lot of the stories, we already managed to achieve this year quite a lot of the things that were impacting the patient or the colleague. So I would challenge us to extend those stories and look further forwards and think about how we could really sell what we're going to try and achieve in the next few years. And then the other thing that came out of those stories for me is one of the things that seemed to make that the staff in particular were saying made an impact on them was standardization. But I didn't see that in the strategy itself as something we were trying to achieve. So I just wondered whether we wanted to pull that out a bit more. And then my other thought on the sort of strategy piece overall, and particularly the clinical strategy, I think actually speaks to what Richard said in that introduction there, which is the next piece is to understand how they intertwine and what that actually means. So for me, the really crucial thing with a strategy is it enables the people in the organisation to actually take decisions. So our strategy generates within our organisation a pattern of decision making, which is the one that we want to achieve our objectives. So telling those stories, perhaps again, about what these strategies mean for people within the organisation and our patients, about what the future looks like, just as a sort of a guiding principles.
Can I come back on?
Yeah, do.
Because I think, Nikki, that's really, I think that you raised some really good points. And again, I think there was a wry smile from Damien when you mentioned, are we being ambitious enough? So I'm going to let him deal with that. I think, I mean, you know, you recognise that the work that's gone into digital, and we, you know, the board has seen before the work that particular team has done to support the wider Sussex ambition. And I think it's worth noting that as Adam Doyle shapes up his executive team, there is going to be a chief digital and transformation officer. So I think, again, us being at the forefront of digital work across Sussex and enabling that, I do think puts us in good stead. Coming on to the intertwining, I think you're absolutely right. And this goes to the point about having a clinical strategy, but also ensuring that the service strategies are also available. So we built the clinical strategy at a trust-wide level, but actually we always said at the very beginning, if you remember, I think it was Joe that said, I want every new consultant that joins this organisation going into a specialty having a sense of what that particular specialty wants to do, where it wants to go, what its priorities are for the next 5 years. And I think we've got that. I think that is also shaping how we're looking at business planning for this year and beyond, because of course business planning will move to a 3-year approach and programme as opposed to the annual slice that we do currently. And I think that also talks to Joe's point about needing to stay under constant review, because, you know, for example, urology has its own little mini service strategy there, but we also know that within the system there are going to be certain pressures that are brought to bear. There are certain, you know, thinking about how we do these things are going to change. So I think we do need to recognise that when we review these strategies, we will also need to review the underpinning service strategies on an annual basis as well, checking back in with the teams that not only do you think this is the right thing, but actually what we know from how place and system is evolving to maintain that sense of fit. Damien's smiling even more now, so I'm gonna stop talking.
Damien, did you just want to add into that particular part of the discussion?
I'm trying to work out how smiling is a bad thing.
It's a good thing.
So can I just focus on, I think we haven't used the language of integration because it's basically it underpins the entire thing. What this is really about is delivering within the trust, at least delivering a single patient record, and that by doing that, I mean, yes, delivering it system wide as well, and yes, delivering the HIM standard, but actually basing everything in terms of people accessing the same record just in multiple ways will be huge. And actually a concern is how we link this to the clinical strategy and make sure people own the scale of change that will be needed to deliver it. So my concern, I think, is actually about how we link these strategies and make sure that people see the interconnectedness, which is the bit that worries me.
If I may, Steve, when I was talking about simplification, it was actually as simple as one of the case studies mentioned different meeting rooms having different pieces of kit, and another case study mentioned a nurse working on a ward where we'd introduced the wonderful system where you can access notes on some sort of handheld device, but a different ward used a different device. So that's what I meant by the simplification. So actually that standardization, making it easier for staff to move between places or work in different places. It was quite a practical thing, and it just happened to come up in a couple of case studies, and it felt like maybe that was actually something that our staff really cared about, but hadn't quite made it across into the strategy itself.
Yeah, I think that's a good point. That's a good point. Jackie.
Thank you. I think it was just to emphasise probably what Richard and Damien have been saying, that the enablers are really estates and digital, because they will fundamentally change or enable us to change how we then deliver a clinical strategy and a people strategy. So it being plugged into the ICS and perhaps leading them to the cash till and making sure that we got that investment, because if we don't get the investment, particularly in digital, we can't then enable the clinical teams and the people to work in different ways.
Yeah, I think we'd all support that for sure. Karen.
Thanks, Steve. So, I mean, I think we've made tremendous progress with the overarching strategy and the 4 enabling strategies from where we were like 5 years ago. I think it's a real step change in terms of where we've got to. And so I'm wondering, going forward, how is the board going to be assured that we're actually making the progress that we want against each of these strategies? So how are we going to know, or what's the process going to be for actually knowing that we've achieved the milestones? I think virtually every one of the strategies had a roadmap on it. So it's kind of like this is new to have this level of strategic detail for us. So kind of how does that go into our processes now?
You've put your hand up, Joe. Did you want to respond to that?
Well, yes, and Richard might want to come in. So I think Richard alluded to the fact that at Stratcom we would be taking, Richard will be taking a paper on how we assure and deliver against the strategies. So I think there's probably a wider conversation there. I suppose in my simplistic answer to that is that we are, as you know, looking to invest in our transformation team. And I've always said the strategy is the what and the transformation is the how. And there will be, and there already are, but there will be an enhanced level of programme oversight and change team to be able to ensure delivery of that. I think I need to reflect with Richard and probably Damien specifically on the actually and Stephen on the people strategy element and the digital strategy element, because I don't want to create a massive industry, but you and I as well need assurance on those strategies as well. So just need to have a bit of a think about how we do that without loading it all into one person's portfolio around assurance.
Yeah, and we need to use the subcommittees, don't we, appropriately in order to pursue those. Richard, did you want to add to that?
It was just a small thing, really. I totally, just on your last point, Steve, I totally agree. I think part of what we need to do is we've got a bunch of priorities that within these, we need to divide those up across our own internal governance structures so that individual board subcommittees own various priorities. That would be my preferred approach. But as Joe says, we're working that through. I think the other thing just to add, and we've already touched on it, again, I think there is a very strong steer coming through the ICB that place is where performance, delivery, transformation is going to come together. So I think as we develop this internal assurance process, we also need to make sure that the transformation, as Joe said, the how we do stuff fits back to the programmatic approach and priorities that we know place is going to have. Now, we've done, as we've talked about, we've done everything we can to align our own internal priorities with where we think the system and place are going. We just need to maintain that sense that as the ICB, as Adam and in particular takes a view on how place leadership shapes up, we're just making sure that we're plugging in what we think our priorities are and how we're monitoring delivery against what the system and specifically place is expecting around transformation and integration.
Thank you. Amanda.
Thank you. I think my 3 points have been covered, actually. I wanted to, one, commend you. This work is so much better, really clear, and I love the liveliness, particularly of the digital report, but most of my colleagues have talked about that. I also like on page 9 of 36 of the digital strategy, how that is laid out in terms of the timeline. And I think the comment around the interdependencies of each of the strategies and a timeline like that could be very helpful from an assurance perspective. But Richard, it was also to pick up on the point that you've just answered, actually, which was now that we've got our house almost in order or are getting it in order, how do we represent the integrated nature of our plans for primary and community care with the place-based system? And I think from what you've just said, that's kind of unfolding as we speak, but something that we need to participate in and lead, I would suggest.
I agree. Absolutely.
Yeah,
I think that's right. Jackie.
Just and I should have raised it earlier, really, that as an integrated trust, we should be showing the ICS how to do it. And if we must be able to demonstrate how being an integrated trust is better than being an unintegrated trust. And we've got more ability to change those pathways and manage access to services than anybody else in our ICS. So it is really important for us that we can demonstrate how better we can do by being integrated. Yeah, I agree with that. And we need to do it by looking by reference to what we're going to do going forwards, as much as by demonstrating what we've been able to do up until now. We don't want to sit back on past successes, which I know everybody agrees with. Okay, so shall we draw that to a close? I think we're asked to formally approve the 4 enabling strategies, and unless anybody tells me different, I'm going to do that. Good, thank you. Joe, for item 10, the green plan, it was going to be Chris. Chris has had to go to a national meeting.
It's Richard.
Okay. So the plan itself has, rather like the other enabling strategies that we've just looked at, has been through various committees for assessment. I think board members have seen it. But Richard.
Thank you. Thanks, Chair. So, again, as you say, I think this is a neat segue really from the strategies into the green plan, which is we've got to do all that good stuff we've just talked about, but it needs to be done with a reduced carbon footprint. So I think the green plan, as we've talked about, we've worked with SCFT to develop it within the Care Without Carbon frameworks, which I think is referenced within the document. This will be adopted within the ICS. And we have 3 key aims that we've set out on page 3 of the document: reducing our environmental impact as an organisation, improving well-being of our residents, and also investing in the future. I think something that Chris mentioned to me when we were discussing this was that the plan helps ESHT to deliver the NHS national net zero targets for 2040 to 2050. And we've got a specific aim as an organisation to reduce our carbon footprint by 57% by 2025 using 2013-14 as our baseline. I think we already would point to, and I think the document points to a couple of examples of how we've already done that. So in medical gas anaesthetics, there's a 43% reduction in emissions per litre by switching to alternative sources. Our use of reusable sharps, containers avoided, is in terms of containers going into incineration has been reduced. And I think on page 16 and onwards, what we set out is this will be reviewed in a fairly programmatic way. We've got a trust lead for each of the work streams, and we are required to update the board annually on our progress against all of these actions. Chris also said that there was that I should inform the board that we also have a public sector decarbonisation round 3 fund, that's easy for me to say, bid that's going in for a significant amount to support us in doing this. So if we are successful in that bid, and we very much hope that we will be, that's how a lot of this work will be supported going forward. I'm happy to stop there and take questions insofar as I can.
That's great. Thanks, Richard. Jackie.
I think this strategy would benefit for some sort of annual targeting or something, because it's good on what we need to do, but some of the detail behind that I think is a bit light. I think there's a couple of things pushing against us, like PPE is pushing up our clinical waste and reusables. I mean, from mad cow disease, we went madly into everything is single use, and whether or not we can get back some autoclaves and a bit of steel to start reusing some stuff. So some of our advances has left are working against a green plan, I think. So, not 40-50 is a long time away. I noticed that 24% of our bad stuff comes from our supply chain, and therefore, as the NHS, as a major procurer, of which we are a cog, is there a national programme to really work with our supply chain to get that down? It would be better at a national level rather than all of us working individually. So that was it from me. Thank you.
Those sound like challenges to be posed. I mean, particularly we'll need implementation plans and so on. And I guess then a couple of challenges for Chris and the more detailed implementation. Very tricky around the supply chain, I think. I think Jackie. Miranda.
Thank you. I was very pleased to see this, because when I worked at the Environment Agency a few years ago, the NHS didn't really have much to say about the environmental space. So it's very good that they're now embracing it. What I wondered was, and I couldn't really see this in the report, is are we measuring the travel of our staff, other than business travel, but travel to and from work, in our carbon, and also the travel of patients to our facilities, because I would have thought that was actually quite a large part of our carbon footprint. However, if you tell me that the guidance perhaps from the NHS centrally is that we're not to include that, then fair enough. Obviously, we don't want to be different from everybody else, and you know, we need to, apples need to be compared with apples, but I wondered if that's included because I can't actually see it and I would have thought it was quite a large thing. So that was my first question. My second question was a little bit related to what Jackie was saying. How are we going to win over hearts and minds and also make sure that our leaders feel they're fully invested in this and accountable for it?
Good questions. I mean, I don't know if you know the answer to this, Richard, but I mean, certainly in terms of the footprint of staff travelling within work, it must have gone down enormously since the use of Teams and social distancing, etc., etc. I think travel to and from work, both for staff and patients, would be interesting to know the details of, but I'm not sure what we could do about it too much. But it would be interesting to know, wouldn't it? It would be interesting to know.
With patients,
Oh,
sorry, just to whiz in, with patients, it would be difficult to do anything about it. With staff, you can have green travel plans, but again, the geography may count against you because of the number of people who live in the country and the lack of public transport, etc. But it is something that can be tackled, and I have seen tackled in the past.
Yeah, I think if you, it's difficult to do that in the delivery of care, isn't it? In quite the same way as it is if you're if you're essentially a kind of administrative or customer service kind of hub. But I think so. Why don't we put those particular challenges in the list of? There's quite a lot for you to sort out, Chris. You shouldn't have gone away for the day. List. Nikki, to be fair, actually, I'm not being fair to Chris because he is at an urgent national meeting. He's not just swan off for the day. Just to be clear, I was just teasing about that. Nikki.
Thank you. Just to add to the list for poor Chris to return to, my thoughts were just it would be really good to see this time into those strategy documents that preceded it. That seemed like the obvious link that needed to be made. And then just how are we planning to measure our progress? What are we actually hoping to achieve and how are we going to measure what success looks like?
Yeah. Karen?
Yeah, I guess Nikki just took one there in terms of how are we actually going to measure it, because I think it's light on that. And just to go back to that point on travel, although it's difficult to measure maybe individually, there was some work done actually probably now, I'm going back 10 years, and travel in the NHS as a whole, not just patients, but staff and suppliers and everything, was one of the biggest individual carbon emitters of all transport in the UK. Sure. It's humongously high when you put all the pieces together. And we say we can't do anything, but actually we want people to do more online consultations and things like that. That's actually part of that conversation is to try and, because lots of people would like to improve our carbon emissions and things. And so it's actually about linking up some of those broader conversations to say, you can have an impact. It's a small amount, but if everybody starts to have make small improvements, you actually end up with a large one. So I think there's some really interesting thinking that can go in behind this green strategy about how do we actually engage patients and staff in it, that actually can be really positive and really motivating as well.
Yeah, I agree, and I mean that was part of what I said at the beginning, which is, you know, COVID and the use of Teams and so on has, I think, dramatically changed the thinking around stuff. Involving patients is good, but given the experience that patients have so far had with primary care, now might not be necessarily quite the right time to win hearts and minds of patients. Miranda, you wanted to come back, I think, unless that's a legacy.
Yes. No, it's a new hand. I didn't want my point about hearts and minds to be missed, and Karen brought it back, so that's great. And it doesn't surprise me Karen's statistic about the travel to and from appointments in the NHS being a huge carbon emitter, because I well remember when we were doing environmental evaluations at the Environment Agency of, for example, the carbon footprint of Heathrow. The biggest emitter of carbon in and around Heathrow is actually car journeys to and from. So it's always the way, and that is something that can't be left out. So I'm glad we went back to that. But the other bit in my question earlier on was about leaders and accountability of leaders, not just Chris, everybody stepping up to the plate, because you can't deliver these sorts of changes without that. It's true of every change, but I would quite like that to be addressed when Chris gets back from his important meeting.
Quite right, quite right. Damien.
Just on the travel point, I just want to emphasise that actually it is in the document, page 21 and 20 and 21, for both. So there are two streams. One talks about staff travel, and one talks about patient travel. And while we need to do more work on the detail of how exactly we deliver it, there are steps about trying to encourage proper use, trying to reduce the degree of cars coming into work, and there is a chunk on how we're changing patient care to be more focused on care at the home, because that reduces patient travel as well. So the themes are already identified. I think perhaps what we need to do, as I think it was mentioned earlier, we need to do more of the detail of by Jackie. I think we need to do more of the detail of about how we deliver those sections.
Yeah, and I think the issue of the funding that Richard mentioned earlier on, but part of the sequencing of this is to provide for the centre a kind of message that we've got a kind of high level plan, that we know what the main components are, that we know what we can work on, and then some of the funding that's being allocated will help us work through some of that in absolute detail. So there's a sort of sequencing of this that needs to be done. Miranda, did you have another point to make?
I just wanted to add one thing, which is, yes, there is wording about that, Damien, quite right, but the pie chart earlier on in the brochure is silent on the point of travel to and from work.
No, I agree with you about we actually need to get into the detail and actually hold ourselves to account for what we're going to deliver. And I think even Steve's point about the funding, actually the only bit of funding that we've focused on so far is actually about the utility change. So what steps we need to make in terms of these steps. Yes, we've mentioned it briefly in terms of BFF discussions, but we haven't actually got detailed plans about how we deliver. So yes, I accept your point, Miranda. When Chris gets back, we need to hold ourselves to account about how we're going to deliver it.
And have to approve a bit of extra overtime for Chris with the list of things we've just given to him. What we need to do now, I think, is ask the board if they would approve the plan, and I'm going to do that unless anybody raises a hand and tells me not to do so. So approved. Thanks very much, everybody. So let's move to agenda item 11, and particularly warm welcome to Ruth. Nice to see you, Ruth. With COVID, our kind of chats in the corridor and dropping into my office have had to disappear, so I feel a bit disconnected from in recent times. So it's very nice to see you. Before I come to you, sorry, and Dominique, whose face I can't see. Oh yes, now I can. Hello, Dominique. Welcome. Steve, did you want to say anything by way of introduction?
I don't think so, other than obviously I'm very grateful for the work of the Freedom to Speak Up Guardians. I should actually and thank them for coming today to board. I should be clear that whilst it says I'm the reporting officer, this is not my report. This is the report from the Freedom to Speak Up Guardians that's been written independently by them, and I'd be grateful if the minutes could just reflect that, please. But with that, if it's okay, Chair, I'll hand over to Ruth and Dominique.
By all means, over to the two of you to take us through it.
Thank you, Chair. Thank you, Steve. Hello, everybody. I'm going to start a little bit, and then I'm going to hand over to Ruth, and then we're both available for questions from colleagues. So really just present this afternoon to give the board some assurance regarding speaking up arrangements at ESHT. I'm going to take the report as read, just go through a few salient points and then invite comment. The pandemic has been an extremely challenging and busy time for us, as you would expect, and for all guardians nationally. We've seen our cases at about 40 to 60 per quarter. The highest number of speak up conversations that we have are with our registered nurse and midwife community, and that matches the national data as well. Reassuringly, those that choose to speak up anonymously is actually very low at ESHT, much lower than the national average, and those citing detriment for speaking up is also very low, which is pleasing, gives us some assurance, I think, that our psychological safety and culture of speaking up is good. We can continue to strive to improve on that, but we're delighted to learn that on the whole, nobody cites a significant number of reprisals or repercussions from speaking up. So the largest numbers were in Q1, the start of the pandemic, and understandably staff were citing concern about PPE, redeployment, their safety, isolation, and so on. And as the course of the pandemic has evolved, those concerns have changed. We're seeing less of those and moving much more towards conduct and behaviour concerns. There's no doubt that a fatigued workforce has contributed to that in some way. Most of those that speak up to the Guardians have spoken up before, and that's pleasing to know that the reporting channels are being used. They generally come to us as Guardians when they don't feel assured perhaps of a response or haven't received a satisfactory response, and we'll seek to escalate those concerns and work to support them and their well-being. I think a key priority for us are our bullying and harassment rates, which you will see from the report remain higher than the national average. We have aligned ourselves much more with staff engagement and well-being of late, so we are triangulating some of that data and that soft intelligence, and that's definitely informing some of our proactive work to look at how we can support the workforce, and we're part of a working group as well, specifically looking at that topic. I think there is definitely a need for a reset as we come into this recovery period, where we need to revisit speaking up with all of our staff and see it as an opportunity. It's a gift. We need to be thanking staff for speaking up, acknowledging their concerns and providing some robust feedback, and that will continue to be our priority. I'll hand over to Ruth, who probably wants to continue a bit more.
Okay, thank you, Dominique. So again, from an assurance point of view, we continue obviously to promote staff, which they do, and we know they do, to speak up to their line managers, supervisors, and any leads in the first instance where possible. But there's some assurance at ESH now that we have quite a robust, also Freedom to Speak Up Guardian service. Touching on what Dominique said, something that we would like to see an improvement on is when we ask people, have you spoken up, and what leads them to come to us. And some of the intelligence from that we felt over the last sort of year has kind of been around similar themes. So not feeling responded to, not always feeling that the concerns have been seen as a gift, an opportunity to review, support, look at solutions. Sometimes there are no solutions, but sometimes what people need is an acknowledgement. And that's something that we're really keen to work alongside staff engagement in some of the training about when you receive a concern, how we thank staff, when we look to commit to listen and then look at some solutions. And hopefully what we'll see then, not to do us out of a role, is maybe a reduction in people coming to us saying, I've already raised this through more than one route. And how we want to do that in a non-critical way, that's part really of our looking at our freedom to speak up strategy, and supporting leads and managers, because we're here for everyone, impartial, non-critical, and we absolutely recognise the pressure and stress that people have been under, and a commitment to listen, review concerns on a list of already pressured concerns, maybe another reason why we've seen a little bit of slippage. So part of that reset is to support some of the leadership conversations with how to support those concerns, enable local resolution. We've also reported nationally, and we've met all the requirements from the National Office, submitting our data in a timely way, and that is on a public network, so people can look at where we sit with that. There's no real clear guidance other than very under-reporting to Freedom to Speak Up Guardians might be considered a concern, similarly to over-reporting. But I think for us, the assurance to the board is that we have lots of avenues for speaking up, and we can demonstrate that through COVID, even though we may not have been as visible that we've been talking about, people have still contacted us, and we've still been able to support those key concerns. A few just very quick positives for us to share. So from a patient safety point of view, we've had a reduction in our patient safety concerns coming through us, which fits in really with previous staff surveys, with our incident reporting, and that's really encouraging that we know staff will report clinical concerns, but equal assurance given that when we have had patient safety concerns, and there have been some, they have been responded to very quickly in a very timely way, and I've had very positive feedback from staff involved in that. Dominique's touched on the bullying and harassment, and again, nationally we fit with one of the biggest concerns through Freedom to Speak Up Guardians is around conduct, perceived behaviours, and bullying and harassment, and there's again another range of work streams, and it was a trust priority for the bullying and harassment. So again, we want to support and where possible help with some of that local resolution. The speak up culture, again, speaking with the executive team currently as well, we've been looking really again at a bit of a refresh, because we just feel that we could maybe promote a bit more from the top, and also again just be more assured that we say we take concerns as a gift, as an opportunity, as opposed to perceiving it as a criticism or perceiving it as a negative, and use that as a platform to learn and to hopefully share that learning to the board and to others, you know, as we sort of go around the trust. We've already worked on the strategy, and we've had some support from Dr. Simon Dowse, and that's going to hopefully fit in with the people strategies, just a one-page visual. Again, it's a requirement of the National Office, and we've been able to do some of that work. So what we're hoping is that we do give assurance that we're maybe not been as visible, and thank you, Steve, for that. We've been visible at times walking through sites, but again with infection control, Teams has worked really well. We've had positive feedback from staff, and actually when people have finished a shift, they can use their mobile to get hold of you for a Teams call. So actually there's been some really positive feedback from that sort of IT perspective for staff. And again, we want to continue to, you know, work, promote the good stuff, and obviously where there's things that we could improve on to support that.
Great. Well, thank you both very much. I mean, first of all, for a really informative and useful report, but also for everything that you do day in and day out. Joe, before I open things up, anything you wanted to pick up, Joe?
Yeah, so just a couple of things. So equally, thank you to Dominic and Ruth. Really great report. Just so people are aware, and Steve and I do meet with Ruth and Dominic on a regular basis, and whilst we don't talk about individual cases because it is confidential, we do talk about themes. So there is that direct line. I suppose it's a statement from me, and we see still survey reports, we see numbers, but sometimes when you see things starkly in a report without, when you see a big report, sometimes you can lose those individual metrics. I suppose what's going through my head at the moment, and I'll pick up with Steve offline, I'm going to say this, it's not acceptable to have 21% or 20% of our staff feeling they have been harassed, bullied or abused at work. I know it's kind of in line with national. Steve and I have seen the latest results, so we're not out of line with anybody else. I can see on this report that's obviously last year, but it's just not okay. So I think the thing I need to take away with Steve is, how do we make a step change to be the best in the country? And I don't know the answers to that. There's some of the things Ruth and Dominique, so we need to pull out of this report. It's a wider conversation, but I think we need to state that's where we want to be, and that's what we're going to do. Yes, the context is we're kind of in line with us, but that number is unacceptable to me. So I just thought I'm just going to put that up front and centre, really, and we'll need to work through that.
Thanks, Joe. I agree with that entirely. Dominic, did you want to just respond to that?
Yeah, please, and it's really helpful. Thank you, Joe. I think where we need to be clear is that some of the conduct and the behaviours, our greater concern is the proportion of colleague to colleague. And what we have seen is a reduction in those that perceive poor conduct and treatment from managers or leaders. It's much more between our staff on staff. And we review those at DATIX meetings, and we're pleased to be kind of advised of those DATIX. It gives us an overview and we can look at a consistent and robust responses. But there's absolutely work to be done generally, I think, in resetting our culture about how we treat one another and respectful conversations. It's something that Ruth and I dip into daily when we're supporting people, and the majority of the concerns, there is definitely a place for local resolution. And we'll continue to work with that. But yeah, thank you for making the point.
Thanks, Dominic. Karen.
Yes, I wondered if I could just get a clarification around the patient safety numbers, because you said both in your verbal update and in the report that the numbers of patient safety issues had improved, and maybe they have if you're looking at them from 2018 or 2019. But in fact, the numbers that you report in the tables here are 5 patient safety quality for 2020 and 16 for 2021. So that to me seems like the number of cases to do with patient safety and quality actually got worse over the last 2 years, but maybe there's data going further back that was even worse. So clarification, please.
So I think a number of ours initially were in the original phases of COVID, when we did see a big surge of it. I was trying to get the report up, actually. I need to go. Sorry, let me just go into.
While Ruth's just
no, there's only 5. There's only 5 showing for 2020. So the original COVID surge, and the larger numbers are in 2021. So that's why I'm kind of puzzled by it.
Okay, I need to look at the report, actually. Dominic, have you got it in front of you?
Yeah, so some of the patient safety and quality nationally is 18%. So where I'd commented it was pleasing for us is that we're much lower than the national reporting figures for patient safety. And yes, there had been a slight upsurge in the pandemic, which you would expect. There are slight differences in the reporting, in that what we are citing are the numbers of conversations that come to guardians. So we can only comment on those that are brought to Ruth and I. Some may go through other routes, but we wouldn't have that data. Is that what you were meaning?
Oh, can't hear.
You're on mute, Karen.
Can't hear.
You're on mute, Karen.
Can't hear her.
No, he's still on mute, Karen.
Sorry, no, it froze for me. Sorry. No, maybe I'll email you separately.
Yeah, sounds like a kind of technical.
Because the numbers really don't make sense to me.
Okay.
Can I just there was a slight surge in the numbers. Mine's frozen on my other side, on my Outlook side, but there was a small amount of surge, and we put that in our themes. Some of those patient safety at one point were around our escalation areas, and we have fed in around some of that, and that's sometimes maybe it's been because we've been available at that time when things have been happening that have had to happen to support patient safety and our front doors. But I think, again, what Dominic has alluded to is from a national point of view. But I suppose in comparison to our other figures, patient safety numbers are quite small in relation to our key themes and our kind of high recordings, which are systems and processes and behaviours. I can't get onto Outlook.
I guess I don't see that. I think.
Okay, I'll have a look.
16. Well, you had 16 cases in 2021, which is 9.2% of all cases.
Well, let me just suggest we just take this offline and just clarify.
Yeah, we'll come back to that. I'll have a look at it with Dominic afterwards. We'll come back. I'll email.
Yeah, thank you. Steve, did you have something?
Yeah, I was whizzing through, and Dominic and Ruth won't be aware of this, is the step we got our first sight of the staff survey results in the last couple of days. So I was just whizzing through the relevant questions in that, and our most improved score, or a significantly better score compared with other organisations in the survey, and it's the one which is pulled out, is I would feel secure raising concerns about unsafe clinical practice. So that was the most positive. That was one of our most positive scores, and the one which significantly improved, which statistically significantly improved the most in the most recent survey. I guess there's two parts to that. Firstly, if people are feeling more confident, they will raise more things. Yeah, and that's potentially a positive thing. But Karen, hopefully that will give some sort of some feedback that staff are feeling more positive and more confident about raising concerns now, and that's seen as a good from the staff survey.
Thanks, Steve. Paresh.
Thanks, Steve. Firstly, thanks Dominic and Ruth for the presentation. One thing which I'd like to understand more, because the biggest category in terms of numbers is actually system and process, which implies that it's not human related. i.e. there's something wrong with our system or process. Can you talk a bit more about that in terms of, and how do we change those systems and process if they're actually harming a patient?
So the systems and processes are kind of a multi-range that we log under, and most of those are staff work related issues. So they link in with things such as flexible working, and obviously we know the trust has had a real commitment to support flexible working. Often it may involve people that are either in an investigation or part of a grievance or part of a conflict in a process, and they're not sure what sort of policy and process. A number of those may be concerns that are dealt with then passed on more appropriately to a more formal process. Obviously the ones that can go back, particularly in relation to things like even things like annual leave. So people will raise concerns about if they feel there's been inequity in annual leave allocation, particularly at Christmas, summer holidays, or people that have asked for flexible working and just been told no, but actually the due process of the application for flexible working, and maybe the guidelines of having a discussion, looking at a compromise, looking what fits business purposes, maybe that could be a little bit more complete. So that's generally a sort of range of work related as opposed to patient safety issues. They're processes and policies, and we have really good policies that guide us with, for instance, bullying and harassment resolution, grievance, disciplinaries. And sometimes it may just be that people come to us because they're feeling in a very difficult place. So that's part of a wellbeing support network, but also about what they can do. So going back to their managers to discuss it. Appraisals comes up sometimes, how people feel that's gone. So we link into a number of those things and hopefully then feed that back to the appropriate people.
Thanks. One follow-up question, if I may, Steve, very quickly. So can you cut the data by sites, so Conquest, Eastbourne, Bexhill, just to identify if there are any kind of areas which are cause for concern, or do you do that behind the scenes and target them?
Yeah, we do. And
Right,
Ruth,
okay.
I'm sure Ruth will want to come in on this, but for every case that is brought to us, we always cite where the person is based and their delegation.
Right.
And then we can look at some of the themes and the trends and particular hotspots. So yes, absolutely, it helps us to identify areas of concern, and then we can target our proactive work and perhaps work with other departments. So our organisational development colleagues are very supportive. If there are particular areas and sites where there have been repeated concerns and themes, then perhaps that would highlight a need for some teamwork there, and we would share that. Yes.
Thank you very much. Thanks.
Thanks, Dominic. Vicky.
Thanks, Chair. So I'm happy to pick up with Dominic and Ruth offline as this goes back to Karen's question about patient safety and quality. If I've read the report correctly, so we've said in 2019-20 it was 5.5%, and then we've seen a reduction down to 2% in 2021. But the data at the bottom of page 3 and on page 4 is only for 2020 and 2021, so we haven't included the 19-20 data. I think that's what you can't see, Karen.
So let's
So
take the
I'll pick it
data
up.
clarification stuff offline, if that's
Sure.
if that's okay. But thanks for offering to pick that up, Vicky. Nikki.
Thank you, Steve. So I think for me, what this report does is it really brings to the fore the first part of your job, which is incredibly important, which is the talking to people or helping them resolve the issues. The piece where I'd love to see a bit more is that final paragraph, which is the learning from your cases. And you've kind of touched on it talking to this report. But for me, to get assurance that we're not only using your wonderful service to help individuals at the time, but we're also improving ESHT, I would love to see your report cover more formally how we're picking up hotspots, how we're picking up themes, and then what our action plan is. So for me, the assurance would be, we have spotted that Department A at the Conquest has an issue around flexible working, and this is what we're going to do about it. And so that next year we can check back in and say, did that have an impact? Are we doing the right things, or is it still a problem? So there's just that next step of assurance, I think would be really great to see more formally within the report.
Yeah, thanks, Nikki. I think we'd need to think just carefully about how that gets translated from the individual to the kind of collective and the specific. I think I agree with you. It's there's some important themes and signals in this for the organisation. Yeah, how that gets translated.
It may be that it becomes a two-part report with some of it to private board. I don't know what it is, but it's just that next step of learning and building and growing would be great.
Yeah, it's a good. Yeah, it's a good point. Thank you.
If I could just say, I mean, so some of the key areas, and again, a little bit like we're not tasked with resolving, but we are tasked with ensuring that intelligence is shared. So some of the key hotspots, or if there were key concerns, we do share with the executive. So we would share with Joe, Steve, Vicky. So definitely we will have direct contact, and part of ours then is saying, how do we learn from that? And then we have fed into some of, for instance, the DATEX meetings, some of the policy application, some of the thoughts around that. We have talked about a little bit about, you know, some people would come and share their experience, but again, that's quite tricky, and probably in a closed board because of all the reasons of confidentiality and how difficult it is for some people to share their journey. But again, we've had some very positive outcomes that, again, hopefully we've shared with Joe and Steve with some of the sort of positive outcomes, and again with Vicky, some of the cases. So maybe that's not in the report, but again, just to give you some assurance, that is kind of something that we do really try to do with the learning and the sharing of those key concerns.
Thanks, Ruth. Joe.
I was going to go back to, I think it's Paresh's point, but let me just cover off Nikki's point. I think we need to be, so Ruth and Dominique are not part of the HR function. So I think the assurance around learning is for Steve to pick up through his committees, because this is one lens of information And what we need to do is triangulate that with all the other information that comes in. So I think it's the right question, but I don't think it's this report. And apologies if it wasn't fresh, but somebody asked the question, I can't remember what the question was now, but the answer was, when Ruth, Dominic, myself and Steve meet on a regular basis, part of that, what we do is triangulate all the information. So actually, no, I can't remember whose question it was, but it was about, can we split the information by site? We will pick up themes in that, and in that triangulation, if there is some feedback coming from Department A on site to X, Steve and I will pick up and go, well, hang on a minute, are there some cases that are coming through? Is there something coming through an IPR report? Is there something going on that's wider, that rather than taking this as absolute? So it's a stream of information that comes in, and Ruth and Dominic are very good at maintaining the confidentiality, but we do absolutely try and work out where those themes are that we need to be able to press on. So I just thought I'd feed that back in.
Great, thanks, Joe. So let's draw that to a close. Dominic, Ruth, thank you again for the report and for all that you do. Good to see you and hear from you. So thanks very much.
Thank you very much.
So let's move on to agenda item 12. I have to say I am failing dismally in my responsibilities for timekeeping. I think we're 3/4 of an hour behind time. So Steve, gender pay gap.
I'll take that as a hint as well, Steve. So
well done, Steve.
So this report presents the 2021 gender pay gap, which is a legal requirement for all organisations to produce. Once we have been through board, this will go onto our website. Just a reminder, gender pay reporting is not about equal pay, it's about the differences in average pay between men and women in the workforce. And just another reminder that with the exception of very senior managers and medical staff, NHS terms and conditions of service, i.e. agenda for change, is the thing which actually determines how we pay people. Inevitably, because that is linked to length of service, you know, we will see some anomalies which are sort of unintended consequences of the system within which we work. I'm going to take the report as read. There are just a couple of points that I would just want to bring out from it. Firstly, on average, men are paid 21.5% more than women, and this has remained relatively static since 2019. This is predominantly driven by medical and dental staff, where the difference is 19%. Agenda for change is slightly the other way around. Same for bonuses, sorry, the same for hourly rates. In terms of bonus payments are linked exclusively to medical and dental staff through the Clinical Excellence Awards. And there remains significant differential here, but this is reduced by a third in the last year. A proportion of men receiving bonuses is significantly higher than women, but the gap has closed year on year for the past 3 years, although it's still 75% to 25%. Now, that gap, the 75 to 25%, and the proportion is governed by the current CEA rules, which actually state that the CEA bucket or pot of payments is split equally amongst all staff. That means that at the moment, because of the COVID rules that are in place, there will be no change to the measurements, and there cannot be any changes to the measurements because all of the payments and who gets CEAs is utterly governed by the regulations. I think probably it's clear from the report the most significant differences we're seeing are in the medical and dental population. That's where we're doing a lot of work at the moment. We've actually started a consultant women's network, and that's about to have its second meeting, and that's looking at how we can support female consultants in progressing their careers. But as with Agenda for Change, there is a massive part of this is determined by length of, by the actual numbers of staff and the length of service of staff, and that does include medical and dental as well. So this is not something that would change overnight. An important aside is we are required to report the gender pay gap at board, but gender, of course, isn't the only way in which we need to look at equity and pay, and we do look at it in other ways. So another way we look at it is, for example, through ethnicity. And we did a report recently on ethnicity, which demonstrated that there are no ethnicity pay disparities in our consultant staff groups, which is one of the groups we talked about earlier. There are some areas where BAME staff are more than white colleagues, and there's areas where white colleagues are more than BAME colleagues. But we can reasonably draw the conclusion from that piece of work that there's no widespread institutionalized differences on pay based on ethnicity. Coming back to the unintended consequences, though, one thing I do want to bring to the board's attention, it is not in the gender pay, it's actually in the ethnicity pay, is that our BAME nurses statistically get paid less than our white nurses, 12% less. This is actually because of the proactive approach that we've taken to bringing on board and supporting international nursing, and comes back to the length of service. 16% of our nursing workforce now is through international nurses, so 321 nurses, and that actually has an impact on our figures. And I raise that just to again make the point that there are a range of unintended consequences to the actions that we take to ensure that we deliver safe and appropriate service. I'm going to stop at that point and just open to any questions.
Thanks, Steve. Let's start with David, who's been wanting to get in for a little while.
There's something odd, Steve, about the bonus payment data, because as a result of the pandemic, the CEA rules were changed, as you alluded to, and so they were divvied up equally between all eligible consultants. So every single consultant who didn't have a national award or level 9 award was given a fair share of it. And that we have over 200 consultants. So I don't understand how only, so the previous years look right, but the March 21 data just looks odd that only 96 consultants received a bonus, because it should have been over 200 consultants receiving a bonus, and it should have been absolutely, so every single consultant who's not a locum in the trust should have had a bonus. So there's something very odd there. So before that goes out, could we just sit down and look at that? There's something very strange about that data.
I will check it. Sorry, my admin controller is just frozen, so I can't get to the report.
Yeah,
so but yes, I will. Yes.
Yeah, very strange.
Thanks, David. Jackie.
Thanks. So I think with the international nurses, that's just a factor of longevity, which can be easily explained, isn't it? Can we cut the pay by taking out the CEA awards? If we took out the CEA awards, have we got parity then? Because every year we hear how much they're skewing it. So it's difficult to know if you took that out what our position would be.
We can take it out, Jackie, and I'm very happy that we that we do that. Effectively, what it will show is that we've got more long-standing male consultants than we've got female consultants, and you have this impact of time of length of service again, which directly impacts on pay. So in essence, it won't make that much difference to the picture, because we're governed by national negotiations and national pay rules.
So where can we have any influence? Because if agenda for pay is agenda for pay and incremental points are incremental points, then how as a trust can we change if we have a disparity?
I think that's a fair and an appropriate question, Jackie. We are governed by the gender pay rules were brought in to cover all organisations and not just public sector organisations, which are governed by sort of national pay agreements. In essence, we have very little impact. We can have very little impact on it, but we are required to report it, and we are required to bring it to the board.
Okay.
I'm sorry, it's not a very acceptable answer, but it's the factual.
Yeah, no, I accept the point. It's just, it seems a lot of work for something we can't do anything about.
Yeah. David, is that a legacy hand or a new hand?
That's a new hand. Just in response to Jackie's question, the one area that we can do something about it, or at least we could before the pandemic, and that is to encourage female consultants to apply for CEA awards. Yes. There is no doubt that across the NHS that female consultants are less likely to apply for excellence awards. There has always been an element of self-grandissement in the way that people apply for these awards, and there's no doubt that women seem to be less likely to apply for them. So we
don't have that gene, I think.
No, you don't have that gene. The what I don't know, and there's major discussions about how CEA awards will look going forwards post-pandemic, and it's not likely that they're going to be quite the same. So they're going to be distributed more evenly across all consultants. So that may well flatten out the CEA award payments once the very senior people with national awards have retired and moved out of the system. So, but we have to wait and see exactly what the shape the new CEA award scheme takes.
Thanks, David. Thanks, Steve. Unless anybody's got any other comments, I'm going to suggest we move to the important issue of the Ockenden report and a sort of update. Vicky.
Thanks, Chair. So I wasn't planning to provide huge amounts of information, mostly because at every Quality and Safety Committee, I hope Amanda would agree, we have significant amounts of information, reports, dashboards and assurance, and we have that at every meeting. We also have a full report planned for the April board in public as part of our quality update, a quarterly update, apologies, going forward. So this is really just a verbal report. So hopefully the board will recall that the Ockenden report was published in December 2020, and the Trust had completed a multidisciplinary benchmark against the report's 39 recommendations. In June or July 2021, we submitted evidence onto an online portal to support our declaration that we've made in February, with over 300 documents uploaded. There was an initial assessment by NHS England colleagues, and we challenged that, and further reassessment gave us a higher compliance rate. There is a meeting being arranged with our regional midwifery officer to review evidence, but I'm pleased to say that current position shows that 34 of the 39 actions are complete with assurance provided, and there's just 5 actions in progress at various stages. And as I've said, the detailed reports are provided and discussed at every quality committee and also in some detail at the maternity assurance meeting. But I'm happy if there's any specific questions or if Amanda has anything further to add from a quality committee point of view.
Sorry, I couldn't get my thing off mute. No, thank you, Vicky. I have nothing further to add except to say that through the Quality Assurance Committee, we do have a robust conversation about this. We drill down into the details of some areas that were actually a little bit ambiguous to begin with, like feedback from maternity patient voices. There's still some way to go. We've got to move these 5 areas where we are not compliant, and there's a focus on that. But I think drilling down when we meet next at board will be very helpful. So nothing more to add, but to thank actually Emma Chamberlain, Vicky, for all their leadership. It's been a huge learning curve and quite a lot of detailed work behind all of this. So, and it's not just those 2, it's the rest of the department. They've got a real focus on this.
Thanks, Amanda.
Thanks, Vicky. Thanks, Amanda. So we look forward to, I think Q&S will look at the final report and then here in April. So we'll look forward to that that important report. Charity annual report and accounts, Damien.
Just in the interest in time, I will try to keep this short. There's two bits in the paper. One is a brief outline of what is the current level of spend over the last 9 months, and then the formal bit is confirming that we can sign off the annual accounts. And I sort of suggest if you want more detail, it would perhaps be appropriate if Karen and I do a double act if you can to answer any questions.
Okay, thank you. Are there any questions? Anything particular you wanted to say, Karen?
Not really. I think it's all fairly self-evident. I think that maybe one note is we had significant income in 2021 because we got a large chunk of money from NHS Together.
Yes.
That won't be going forward. And all the fundraising activities at the moment, or most of the fundraising activities at the moment, are still on hold because of COVID. So the picture may look rather different next year. So we didn't spend as much in the 2020-21 year as we might have, just to make sure that we're holding some back there.
Okay, Jackie.
Just a quickie on the lottery. It doesn't seem to have contributed very much. Is that again a COVID thing, or do we need to do more to encourage people to take part?
It needs promoting further, and we were going to promote it, in fact, on Facebook. It turns out that we required to have our own standalone website as the charity, not as part of the ESHT website. So first we have to build our own website before we can start promoting it on social media. It's part of the lottery fund requirements. So we will do some more with it. But yeah, I don't think it's ever going to be like the national lottery, let's say.
No, I think that's for sure. Nikki.
So just to confirm, Karen, is the expectation that going forward, sort of significantly larger amounts will be paid out, because obviously there's the requirement for charities to kind of give out, if you like, or invest the money that they hold rather than hold it. And there's quite a large balance of investment sitting with the charity at the moment.
Yes. So the ambition is to spend more, and we have actually reached out to all the fund holders, because it's the fund holders that actually have input there, to actually try and encourage them to spend their monies. Some of the funds didn't have any monies used at all last year, so we're actually trying to drive that forward again to actually get funds, because the general funds, which are the ones that the committee kind of has direct control of, in fact, are not as substantial as many of the individual funds. So yeah, but it is a goal to actually improve that spend position.
Thank you. And just to confirm, have you appointed an investment advisor now?
Yes. And you're now going to ask me who it is, and I'm going to defer to Damien.
No, I was less concerned about who it was rather than that one has been appointed. So thank you.
Yes.
Okay, if there are no other questions, I think we're just asked to note this, Damien. We're not asked to approve it, are we?
It's a good question, I'm afraid. I actually think it should have been approved. But given that we sent the accounts in at the end of January, I think effectively we said that the charity committee gave the approval. That's
right.
What we did.
Okay. So we'll note. We will just note that. Yeah. Good. Thank you. Agenda item 15 about the use of the seal. We haven't done so, so that's reasonably quick. So that takes us to questions from members of the public. We've had a page and a half of questions in from Colin Campbell, one of our regular contributors, some of which are quite detailed, and as usual, our normal practice is to write to Mr. Campbell separately with answers. Although I think we owe him something of an apology for having said that we would write with answers to questions from the December meeting, but have failed to do so. I did just want to pick up. I just wanted to pick up a couple of his questions. He asks whether or not in the board papers that we could talk about the specific concerns that have been raised during the public consultation process, and whether we'll offer specific solutions. I think the answer to that is, in the way that he asked, no, we're not, because it's not our process. There's an independent process to be followed, but the range of concerns that people do raise will be pulled together by the independent group that are doing it, but that will be at the end of the process. He's asked whether the putting back the effective date for ICS to July will have any impact on our operations in the first quarter of 22-23. I think the answer to that is no. And then I think then there are some detailed questions that we'll probably respond to directly under separate cover. He specifically asks whether we will have a kind of frequently asked questions page on the website. I do. My understanding is that we do post responses, the questions and the responses on the website. It's just that we didn't do so last time, so I think that's the way that we will do it. So I don't know if Liz is still on. I can't see from my machine, and whether oh, hello Liz, I can see you now. Hello. As another regular contributor, whether you had any particular questions you wanted to raise from today's agenda.
Can I just, I'll go through the questions that I've got, and then you can just direct them, because some of them might have overlap. I think the MLU, I have raised concerns with Jo Chadwick-Bell, which I know she's looking into, but aside from that, what's the position about the MLU, and is it open, and is it open for overnight stays? Also, for maternity, what is the cut-off time at the Conquest to discharge new mums? Because we've just heard of a few late discharges by about 11 o'clock, which with a new baby, I'm just not sure about. The Ockenden report, I was interested in that item, but I haven't got any questions at the moment. I suppose the 5 areas that we aren't compliant, I'm interested in, but I don't know what they are. Cardiology, I think there's huge concern about the reconfiguration, and I think that's probably across the patch. I think reassurance about the front of sort of the A&E and all what's going to happen regarding the specialist cardiac teams that are going to be based at both hospitals, a bit more emphasis on those to allay concerns about the smaller percentage that are travelling. But I know there is quite a lot of concern, and I don't know enough about cardiology to allay those concerns. Travel is the main thing as well. That's all on cardiology. Visiting, are we having visiting patients back again, and is it still a booking system? And then regarding operations, which I think, you know, people having operations and isolating beforehand, you know, is definitely the right thing. But when you have a cancer operation, possibly in Hastings, I've just heard recently of somebody that's having an operation actually today. And basically they've been in isolation for 3 weeks because they've had various procedures beforehand. It's to do with cancer, and I absolutely agree with it. But then for the partner to have to drop off outside the hospital when the person's not that well, or that's what she thinks is going to happen. I just thought with you know, I don't know what the procedure is, because I don't think people are allowed in, which I understand all of it, but she wasn't clear and I'm not clear. So those are my sort of things. Thank you.
Okay, thanks, Liz. Joe, your hand up is...
I was just going to say, I could probably run through most of those quickly, if that's helpful, and then I'll probably just bring Vicky in for one thing. The MLU is not currently open at the moment. There is no strategic intent to keep that closed. That is purely down to staffing pressures and prioritising home births and obviously the obstetric services at Conquest. But there's absolutely no, we've had this conversation, there's definitely no strategic intent to keep that closed for very long. I'm just going to ask Vicky, the Conquest discharge time, I'm not sure if we know the answer to that, if you need to.
I'm afraid I don't at the moment, Liz, but I will absolutely try and find out for you. I'll speak to Emma and other colleagues.
Thank you.
Ockenden, I think we just note that, and Liz, you've seen previous reports on Ockenden, but we'll bring the paper next time. Cardiology and specialist teams, I think we just have to note that is as a comment, and you're going to feed back, because we obviously saw you, well, not obviously, but for others, we met with you and the wider team on Saturday. So if you could just put those responses back, we can't really comment on that this
Can
time.
I just say thank you very much for meeting with the campaign group and your time there. Thank you.
Okay, you're welcome. I'm not going to lose it. The travel, I think, is all part of the cardiology element. Vicky, visiting.
So, Liz, we did have to make the really difficult decision on New Year's Eve to restrict visiting further, because the local prevalence of Omicron was literally rocketing. We've talked about it probably every day, every week since then. We had a conversation last week in our clinical advisory group. I'm keen that we do look to try and reintroduce more visiting. So to be clear, we've not stopped visiting, we've never stopped visiting, we've had to restrict it. So there are exemptions, there's compassionate visiting, visiting for people who need support. That covers a whole range of things. But the cases actually in East Sussex are still higher than the England average, and particularly at the Eastbourne, it's still very difficult. So we had a conversation last week, and what we want to try and do is reintroduce it slowly and carefully this week or next week. So that will go back to an hour a day pre-booked, but not every single day for every patient. So probably every other day, and just to see if that's okay. We've tried to reduce footfall, especially when Omicron was really kind of surging through December and January. It is difficult because we do have some visitors, smaller numbers, but we do have some who will not wear a mask. They will not be lateral flow tested. We don't know if they're vaccinated, and we do have vulnerable patients and some vulnerable staff. So the last thing we want to do is to have more outbreaks because of that. But that's the plan, and the hope is that in the next week or two, we can start to ease some of those restrictions, because we completely recognise how important it is for everybody and for our staff.
Can I just add to that? Because I knew of a couple of people that literally one had had a suspected stroke and now 3 weeks hadn't had visiting, but the chaplains at the hospital agreed to visit, and both the people that I know of have had chaplains visiting, and I don't think, again, that is sort of publicised enough, because that has made a massive difference. So
I'm glad to hear that, and I'm sorry to hear if there's no visiting. I mean, you know, we have lots of digital visiting, we have tablet devices, there's all sorts of ways that we try to keep patients and their loved ones in contact, even if it's not face to face. But if there's stuff that you want to drop me an email about or give me a call, I'm very happy to pick that up offline.
Okay, thank you. Thanks very much.
Thanks very much, Liz. So that draws the meeting belatedly to a close. My apologies for the poor timekeeping again. Our next board meeting in public is on the 12th of April. For those people who are meeting for part 2, can I suggest we reconvene at 1:30? Would that be all right for people? Great. Thank you very much. See you.